ini dapat berjalan dengan lancar dan baik. Amin, amin ya robbal alamin. Baik Bapak dan Ibu dokter sekalian, acara selanjutnya akan ada welcoming speech dari Dr. Madita Hatakasum, Master of Science Audiology Vestibular Medicine, selaku Deputy of Product and Services Kasum Group. Kepada Dr. Madita, kami persilahkan.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, Om Swastiastu, Namo Buddhaya, dan salam kebajikan. Selamat pagi kepada profesor, konsultan, para dokter spesialis THT, dan juga kepada dokter spesialis saraf, dan juga teman sejawat, dan para insan kasum yang saya hormati. Selamat datang di acara seminar kami dengan tema Balance Diagnostic and Assessment, dan terima kasih yang dapat hadir langsung di SITEK, di Kasum Training Center ini, dan juga yang hadir secara online. And on this precious opportunity, I would like to say welcome to Jack Bennet from UK. He's the international trainer from Interacoustics. Baik, kita menyadari bahwa ilmu di bidang audiologi dan vestibular ini benar-benar sangat berkembang dengan pesat. Dan tantangan dalam melakukan diagnostik dan juga tata laksana selalu ada kesempurnaan di bidang ini. Nah, hal inilah yang memotivasi kami dari Kasum Hearing Center atau SITEK untuk melakukan refresh dan update di bidang audiologi dan vestibular. Alhamdulillah selama ini kita sudah secara rutin melakukan seminar-seminar setiap tahunnya yang bekerja sama dengan para dokter konsultan dan juga profesional secara lokal dan juga internasional. Namun karena 2 tahun ini pandemi, kita sempat terhenti. Namun alhamdulillah hari ini kita bisa memulai lagi untuk pertama kalinya secara hybrid, dan semoga di tahun-tahun yang akan datang kita bisa memulai lagi secara full offline setiap tahunnya. Dan saya harapkan ini bisa banyak manfaatnya untuk tentunya untuk masyarakat sekitar. Demikian dari saya ucapkan semoga seminar hari ini bisa banyak manfaatnya dan banyak ilmu yang bisa kita bawa di tempat kita masing-masing. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih dokter untuk welcoming speech-nya. Baik Bapak dan Ibu dokter sekalian, selanjutnya kita akan memasuki acara inti, yaitu pemaparan materi tentang Balance Diagnostics and Assessments oleh Mr. Jack Bennet, sekaligus diskusi dan tanya jawab, dan akan dipandu oleh Dr. Siti Faisa selaku moderator. Namun sebelum itu, perlu kami sampaikan Bapak dan Ibu dokter yang mengikuti seminar ini secara online dapat memberikan pertanyaan ya melalui kolom chat, karena nanti selama proses acara seminar ini kan kami mute untuk mikrofon yang mengikuti secara online. Ya. Perlu kami infokan juga, kami akan memberikan voucher GoPay atau OVO bagi para penanya ya. Jadi tolong partisipasi aktif. Terima kasih. Oke. Perlu diketahui Jack Bennet ini sebagai audiologist dari International Clinical Trainer Interacoustic Academy, di mana Interacoustics sendiri itu adalah sebuah perusahaan instrumen pemeriksaan dan Kasum sebagai distributor tunggalnya di Indonesia. Oke, baik Bapak dan Ibu. Next, we invite all the distinguished speaker, Mr. Jack Bennet, and the moderator, Dr. Siti Faisa, to come to the front, please. Okay. Sit down. Okay. Berikut saya akan membacakan sedikit CV dari moderator kita, Dr. Siti Faisa Abiratno, spesialis THTKL, konsultan, Master of Science Audiology, Vestibular Medicine. Beliau pernah menempuh pendidikan di Fakultas Kedokteran UGM Yogyakarta. Lalu dilanjutkan mengambil spesialisasi THT RSCM di Fakultas Kedokteran Universitas Indonesia. Lalu Master of Science Audiology Vestibular Medicine di University College London, United Kingdom. Lalu beliau juga pernah mengambil program doktor di bidang ilmu kedokteran Fakultas Kedokteran Universitas Indonesia. Beliau juga saat ini aktif mengajar di bidang audiologi vestibuler untuk mahasiswa koas Fakultas Kedokteran UPN, Atmajaya Trisakti, Departemen THT RSPAD Gatot Subroto, Jakarta. Beliau juga aktif praktek di Kasum Hearing, Balance, and Speech Center di Cikini dan Kasum Cabang Lebak Bulus. Ya, beliau juga pernah melakukan program riset untuk program doktoralnya, yaitu melakukan audiometri tutur dengan kalimat bahasa Indonesia, penyusunan, pembakuan, dan penerapannya dalam tes audiometri di lingkungan ramai atau di Indonesian version of hearing in noise atau Indohin. Acara selanjutnya akan saya serahkan kepada Dr. Siti Faisa. Kepada Dr. Siti Faisa, saya persilakan. Ya, terima kasih dokter. Ya, sama-sama dokter. Enggak, saya menutup deh. Ya, istirahat ya benar. Yang mandu.
Kondisi bahasa Indonesia. Acara hari ini seperti sudah semuanya udah dibagi. Seperti sudah bisa dilihat di dalam program ya bahwa hari ini memang kita banyak membahas mengenai masalah vestibuler yang terutama yang selama ini masih jarang dilakukan ya. Seperti sudah kita juga kemukakan. Pada umumnya kita banyak melakukan tes untuk menilai VOR, PSR, untuk menilai juga kanalis semisirkularis terutama. Nah, kenapa kita kemukakan ini? Karena untuk tes otolith kelihatannya kita masih belum banyak melakukan itu, dan hari ini mungkin Mr. Jack Bennet akan share dengan kita ya mengenai Ocular Counter Roll test, kemudian pen. Jadi ada juga VHIP. Jadi intinya pagi ini akan kita mulai dengan topik yang barangkali sudah bisa dibaca. Nanti sebelum lunch kita ada diskusi. Jadi mungkin bagi sejawat yang online bisa menulis di chat sementara Mr. Jack Bennet mengemukakan topiknya, bisa mencatat di chat di komputer masing-masing. Sementara bagi yang hadir offline bisa mengemukakan langsung, nanti kita siapkan mic. Sementara ini barangkali ada sedikit masalah teknis yang perlu, terutama untuk sejawat yang online, maaf, sebaiknya komputer di mute ya supaya menghindari ada background noise yang akan mengganggu dalam mendengarkan lecture yang akan diberikan oleh Mr. Jack Bennet. So I think it's time for you to start with the first lecture.
Thank you very much. Good morning, everybody. And first of all, I'd like to thank Dr. Siti Faisal for moderating today, everybody at Kasum for inviting me here, and of course, everybody that is attending here, both in person and online. I understand how valuable all of your time is, so I'm very thankful for you for spending some of that time with me today. I'm very happy to be in Jakarta, despite the traffic and the difficulties we have coming here today. It's really important for me to be able to come and speak to you. It's my passion to teach in the world of audiology and vestibular medicine, and so I'm very grateful for you for having me in Jakarta. So thank you very much. a very short introduction to me. I understand, obviously, we've had some introductions already, but just to give you a little bit more context. So I work for the Interacoustics Academy, which is the training and teaching arm of Interacoustics, who are a Danish developer of and manufacturer of diagnostic equipment. I also teach at a few universities on a regular basis, as well as doing some ad hoc lecturing at universities internationally. But the universities I work with in the UK are Aston University, where I also got my undergraduate degree. I work with the UCL Ear Institute, which obviously some people here know very well. And so I'm lucky to be able to teach there sometimes. Then I also teach at the University of Hertfordshire. Is this okay? Oh, to share, yes. Okay, now everybody can see what we're talking about, so that's good. And so I also do some guest lecturing at the Mary Hare School, which is a school for deaf children in the UK, where there is some postgraduate education in educational audiology as well. So I sort of split my teaching time across international audiences at international conferences and events like today, some undergraduate and postgraduate teaching in audiology, and some teaching in educational audiology as well. Everything that I focus on, however, is really in the world of diagnostics in audiology. And so this morning, and we'll try and get back on time at some point throughout the day, I'll do my best. But this morning, we're going to be looking at the vestibular diagnostic toolbox. So really thinking about all of the tools that we have to diagnose our dizzy patients. And then we'll get into a bit more detail throughout the day as we look at other sort of specific parts of the vestibular system and parts of vestibular diagnostics as well. But just to give us a little bit of understanding of the timeline, so where are we now and where is vestibular diagnostics? Well, in 1907, probably the most famous diagnostician in audiology and vestibular medicine, Dr. Bharani, developed the caloric stimulation and the caloric test, for which he received a Nobel Prize. The anecdote and the story that we're told is that Dr. Bharani had a patient whose ears were full of wax, something that we're all very familiar with, and his nurse prepared a syringe of water which was too cold, so very cold water, that he used then to irrigate and remove the wax from the patient's ear. The poor patient obviously then received essentially a caloric stimulation, felt very dizzy, and Dr. Bharani noticed the characteristic nystagmus that we see of the eyes in doing that. So we're very lucky that one person's mistake has led to an entire sort of world of medicine. So in 1914, he received the Nobel Prize. And in 1929, so very, very early on, not too long after that first description of nystagmus, then Myers developed electronystagmography, so using electrodes to actually measure the amount of movement of the eyes. In 1945, then that's developed into caloric stimulation machines. So now it's no longer just a mistake of one nurse that we generate this caloric stimulation, but in fact, it's a specific and needed stimulation of the caloric system. In the 1970s, then the electrocochleography was developed. And so this is again using electrodes to analyze the stimulation of the vestibular system, but this time through auditory stimulation. In the 80s, then research was developed to understand this electrocochleography in more detail. Coming into the 1990s, so in the near past, then video nystagmography was developed. This improved the amount of analysis that could take place with systems, and really is driven by the development of video cameras and the development of computers in order to analyze those systems. In 1992, so really into near history, then we started to look at the vestibular evoked myogenic potential, and specifically the cervical vestibular evoked myogenic potential. Developed then in a few years into the ocular vent, so using two different sites of recording in order to understand different vestibular evoked myogenic potentials. And we're nearing the end of the timeline into much more recent history now. So in 2013, probably the biggest development of the last 10 to 20 years, then the measurement of the VOR generated by each of the 6 semicircular canals separately. The measurement of this in the video head impulse test was developed. Obviously, the clinical head impulse test had been used for many, many years up till then, but the objective measurement was able to, we were able to actually objectively measure this response, and starting to understand then the difference between different types of cards that we see in vestibular head impulse testing. We'll do a lot more on that later on today. So this leaves us in a position where we have essentially a forensic, almost like Sherlock Holmes. We're able to really investigate all of the components of the vestibular system and use what we call a forensic analysis or forensic strategies in order to actually look at 10 different types of vestibular responses. And this really is all focused, obviously, on the peripheral vestibular function. So there's actual end organs, the 6 semicircular canals, and our 2 otolith organs as well. And then coming into the extremely near past, so the very recent developments now, where more development is still occurring, then looking at incorporating some techniques that we might think of being for central vestibular conditions, so looking at VNG, and using those to further understand the vestibular systems in extreme detail. So looking at tests like the Ocular Counter Roll, which we will do in just a few moments, looking at sacudometry, so starting to understand really the neurology of the balance system, and also looking at what's known as torsional eye movements. So rather than just thinking of nystagmus as happening in the vertical and horizontal planes, but also looking at the yaw, the torsion of those eyes as well. It's very difficult, in fact, impossible in electronystagmography to measure the twisting of an eye. So by using VNG, then we can actually measure these eye movements. So that means we have loads and loads of tools to understand the vestibular system. But of course, then we need to sort of drill down and understand which of these tools we need to use for different patients and for different types of conditions. So if we think about the most common reason that dizzy patients come and see us as professionals, then BPPV is the #1 reason that patients will feel dizzy. And this is the case worldwide. And it's the case for different age groups as well. So we can obviously use our eyes to look at the effects of BPPV on particular patients. So just using our eyes to study the eye movements as we put patients into different positions. That's very good. It served us very well for very many years and is still probably the easiest and simplest way of analyzing BPPV. But of course, by using our own eyes, our eyes can be tricked. It can be difficult to focus on everything that's happening all at once. And it's not always necessarily easy to see every movement that's happening when we use just our own eyes. So then using things like a video frenzel, so having a camera just recording the eye movements, which obviously allows us to review those eye movements after they've occurred, which is very, very helpful. And then using VNG systems. So now we have a computer that's analyzing that eye movement for us in the vertical and horizontal planes. Again, extremely helpful. It means that we no longer have to try and calculate the velocity of eye movements on our own. But then we also now have VNG with torsional analysis. So the camera systems are able to analyze those eye movements in the torsional plane for us. And that's really extremely useful as populations are aging. And so more and more of our patients are coming to us with neck and back problems and poor mobility. Trying to get an old lady to move their head right back like this is very, very difficult in just on a bed or in clinic. So having a chair, which means we can move the entire body while keeping the neck and back straight, that means that we can treat many more patients effectively. And then also, again, another aspect of our modern lives is that we have obese patients or larger patients. And if you're anything like me, you know, not the biggest man in the world, then trying to maneuver a very large patient into those positions can be very difficult. So using a repositioning chair just allows us to more effectively treat those patients that classically would be very difficult to treat. So what does it look like when we use these to actually analyze eye movements? So here we have a case of BPPV. Let's get this to play. It was working perfectly earlier, obviously. Let's try again. There we are. So now we can see the eye movements as they occur. We can see this torsional eye movement here. Not always easy to look at that and understand exactly what's going on while moving your patient into position, while keeping their eyes open, and while your nurse runs into the room and says there's a problem going on somewhere else, and you have to shout at them and look at your patient and see what's happening. So being able to record these eye movements and then having the computer actually analyzing those eye movements for you is extremely useful, because we can identify the time at which nystagmus occurs, and we can identify the plane in which it occurs as well. So all of the horizontal movements are analyzed here. The vertical movements are analyzed here. I just realized our colleagues on the computers won't be able to see. So our horizontal eye movements will occur here, vertical eye movements here, and then the torsional eye movements are occurring in this bottom row here. So we can see the time at which that nystagmus occurs. We can go and see and look at the nystagmus as it occurs. And then we also have an analysis of the speed of that movement as well. So the degrees per second of movement, really, really helpful in understanding which canal which ear the nystagmus is actually occurring in. This is a world away from holding open someone's eyes to see some movement. I have a very good friend who works in an emergency room in Birmingham, one of the bigger cities in the UK. And in the emergency room, they don't have all of the equipment, but the #1 reason for attendance in an emergency room in the UK is dizziness. The #1 reason for dizziness is BPPV. So my friend calls me on a regular basis and says, I've got somebody with BPPV, can you tell me what's actually happening? And it's very difficult to do that over the phone. I can't see his eyes. Tell me what's happening. They're going all over the place. I can't help you. Stick some goggles on them, record those eye movements, and then we can actually have a good conversation. Luckily, about 80% of BPPV is in the posterior canal. So I just say, do an et-play and see what happens, and we'll probably be okay. So that's very useful when my friend calls me, but this is also extremely useful when I have colleagues all around the world and we're trying to share knowledge and try and share understanding. Then having recordings like this that are very quick and easy to do allows us to, as a community of doctors and audiologists, together and working together. So if you don't see patients very often with conditions like this, then we can all assist and help each other. So that is BPPV. So I mentioned earlier the 10 touch point approach, looking at all of the different vestibular end organs individually. This helps us really to drill down and identify exactly where the injury or the insult to the vestibular system is occurring. But of course, that does mean in order for us to do this, that we need plenty of equipment in order to individually assess each of these organs. it's very difficult to directly, in fact, impossible in most cases, to directly analyze and interfere with a vestibular end organ. So we need to use different testing techniques and different testing equipment in order to pull out the responses of those of each of those organs. So direct access to any one of these organs is actually extremely difficult. But with the correct equipment, we can analyze each of those end organs separately and individually. So if we want to look at what's going on in the posterior canal, then something like BPPV, yes, we can move the patient into that position. But if it's not BPPV that's affecting the posterior canal, then we need a way to assess that. And so by using the VHIT test, we can assess the posterior canal very easily, just by doing a particular type of movement with the VHIT. That also gives us a little bit of information then about the vestibular nerve, and in fact, the inferior branch of the vestibular nerve. So our vestibular nerve here splits off into these two separate branches, the superior branch and the inferior branch of the vestibular nerve. We're very lucky because each of those two branches will split off and innervate the different canals and the different end organs separately. So the posterior canal here is innervated by the inferior vestibular nerve. That is also the case for the saccule. So one of the otolith organs is also innervated by the inferior vestibular nerve. So that means we have a way of analyzing the posterior canal and the saccule separately with the CVEM. So that gives us information about the inferior branch of that vestibular nerve. We have the same sort of concept then with the superior branch of the vestibular nerve. So we can analyze the horizontal canal very easily. Again, VHIT, but also caloric testing. So our most loved, well-known vestibular test, the caloric test. Then we can look at what's going on in the horizontal canal. Same for the anterior canal. We can use VHITs again to analyze the anterior canal. And we can use the OVEMP or the OCR test to analyze what's going on in the utricle. So by doing all of those tests, we can therefore understand what's happening in the superior branch of the vestibular nerve. So we have this, as we say, this forensic approach to actually tease out information from each of the individual organs and therefore really understand what's happening in the vestibular nerve as well. So let's look at each of these again. The horizontal canal we can analyze with the caloric test and with the VHIT as well. The anterior canal really is VHIT that we're focusing on. Posterior canal, again, VHIT is very important. The semicircular canals respond to rotational movements, okay? So where our otoliths respond to translational movements, so in the horizontal and vertical plane, then the semicircular canals respond to this rotational movement. Each of the canals is aligned in a particular direction, so they respond preferentially to particular types of rotational movement. So the horizontal canal, very obviously, just that sort of movement in this plane, innervates the horizontal canal almost exclusively, not entirely exclusively, but almost exclusively. And then movements in this plane for rotational movements stimulate the posterior and anterior canal. Looking at the caloric test, so a test of lateral semicircular canals and lateral only, and this is because of the physiology and the anatomy of the semicircular canal. The horizontal canal is the one that is closest to the middle ear structures. And so as we heat or cool the outer ear, then that heat transfer through the middle ear to the inner ear canal. By doing the caloric test, we can create a baseline for vestibular function in progressive diseases or degeneration. So that's really important if you've got a patient who maybe has a degenerative disease of the superior nerve or the vestibular nerve itself. We analyze the response today, tomorrow, in 1 week, or in 3 weeks' time, and show and sort of map the degeneration of that nerve by doing caloric tests on a regular basis. In that way, we can understand how the disease is progressing, whether it's speeding up, slowing down, coming to the end of its degeneration, or starting its degeneration. We can examine low frequency changes in the peripheral vestibular system. So when we say that rotational movement innervates or generates a response in the vestibular canals, much like in a hearing test, we know that frequencies of low frequencies, high frequencies, there's different effects going on. The same occurs in the semicircular canals. So the caloric test actually stimulates the semicircular canals, the horizontal canals, at a very low and slow rate, okay? So they generate a response that's roughly equal to 0.003 hertz. So really, when we do a caloric stimulation, it's like moving a patient's head sort of this fast. It's really slow. It occurs very, very slowly. But some vestibular conditions are only seen at low frequencies, whereas some vestibular conditions are only seen at high frequencies, at fast movements. So the caloric test allows us to analyze those low frequency movements. One of the absolute best things about the caloric test is it stimulates horizontal canals in one ear at a time. So this is really unique to a lot of vestibular testing because our vestibular systems work in what's called the push-pull manner. So as you stimulate one canal, you're actually inhibiting the other canal. And when you move your head, if I move my head to the left, I have to move both sets of horizontal canals. In the caloric test, however, we can generate movement, or we can generate the flow of the fluid in the semicircular canals. We can generate that in one ear at a time. And in that way, we can truly independently analyze the left or the right horizontal semicircular canals. The problem with that is that we still need to stimulate both separately, and we can only analyze them in reference to each other, okay? Or in reference to normative data, but really we're only analyzing them in reference to each other. The VHIT test. So this gives you the ability to measure each of the semicircular canals now. So where the caloric test only looks at the horizontal canals, then the VHIT allows us to measure all of the canals. Used as a triaging tool in many situations. So using VHIT can help you triage patients with stroke versus a peripheral insult very easily. And again, stroke, a very common reason for dizziness and common reason for somebody entering the emergency room. We can also see vestibular compensation occurring when we test with VHIT. So because it objectively analyzes the saccades that occur, then we can see over time, as somebody's vestibular condition improves, we can see an improvement demonstrated in the VHIT test. And again, we'll look at that in much more detail a little bit later on today. But essentially, we can see the saccades occurring earlier and earlier and earlier until essentially the saccade, so the reactive eye movement in VHIT, that can occur during the head movement. So by the time the head movement has finished, the patient's eyes are resting in the correct position. Conditions like vestibular neuritis, which may spontaneously recover over time or spontaneously improve, we can actually show that improvement occurring over time by using the VHIT. And of course, as I said, we can use it to differentiate between stroke and acute vestibular syndromes. And again, we can also use this as a baseline to track the progression of the vestibular function in a degenerative disease. Okay, so we've looked at the semicircular canals now, so now we can look at the otoliths as well. So for the utricle, then we can analyze that by using the OVEMP, the Ocular Vestibular Evoked Myogenic Potential. And then for the saccule, we can look at the CVEMP. And that's because the systems work in slightly different ways that we'll look at just now. So the way that the C-vamp works is that by using a stimulation of by stimulating the saccule, we can look at the cervical response to that. We use sound to stimulate the saccule, and that's not because it's a hearing organ, but obviously sound being vibration, we're essentially shaking the saccule. That's all we're doing with the C-vamp. By playing a loud sound into the ear, we shake the saccule. So we shake the saccule, and then that response is generated. So the nerves are innervated. So the inferior vestibular nerve is innervated, moves to the vestibular nucleus on its movement into the brain, and then instantly through the vestibulospinal tract, and then through the 11th spinal accessory, and then into the sternocleidomastoid mastoid muscle. So a very quick response to that is that the sternocleidomastoid muscle here is essentially released. So you put it under tension, play a sound into the... Okay, so by doing that, by measuring the response in the neck, we can see the function of the saccule. It's ipsilateral, so if you stimulate the right ear, then we will measure it from the right side of the neck. It's uncrossed, so it stays on that side of the brain, and it's inhibitory, so that means that the muscle is relaxed when the response occurs. And so when we see it on the Eclipse system, on our EP systems, we see a contraction, an inhibition of the muscle. So the muscle relaxes. The ovamp occurs in the same way. That is that we stimulate it with sound or with vibration. We essentially shake the utricle. So if we play that into the right ear, play the sound into the left ear, excuse me, then the left utricle will be stimulated. That is on the superior vestibular nerve, as we saw. Again, at the vestibular nucleus, that's the point at which it will swap over before going to the medial longitudinal faliscus, to the third oculomotor central nerve, and into the right inferior oblique muscle, which is just under the eye. So this is different to the C-vamp in that it's bilateral, crossed, and excitatory in nature. So we stimulate to the left ear, but we measure from the right eye. And we measure from the very small little muscle just underneath the right eye. And this time, rather than the muscle inhibiting and relaxing, the muscle contracts, okay? The big difficulty with the O-vamp versus the C-vamp, obviously the sternocleidomastoid mastoid muscle is a very big muscle. So measuring the response of that muscle is very easy because there's a lot of electrical activity that occurs. The inferior oblique muscle is under the eye and is very, very small. And so the amount of response coming off that muscle is very, very small. And so analyzing that muscle contraction with the noise of all of the other muscles that are on the face can be very difficult. And so the ocular vamp is actually very difficult to record in many patients. Especially some of your older patients, it's actually very difficult to record this. And so we do say that if you don't see an O-vamp response, that doesn't necessarily mean that the utricle isn't working. It just means that you weren't able to record it in this patient. If, for example, you can record it in one eye and not in the other, then that gives you a very good indication that the utricle on that one side is not working. But if you've got bilateral absent O-vamps, it's very difficult then to say that the utricle isn't working, because it can't be recorded in all patients, even with normal utricular function. So having the O-vamp and the C-vamp is actually extremely useful because, as we've said before, we're trying to analyze these different branches of the vestibular nerve separately. So the O-vamp records the function from the superior vestibular nerve, and the C-vamp records function from the inferior vestibular nerve. So having both means that we can, again, independently analyze what's going on those vestibular nerves. So all of these conditions can be measured with the vamp response. So utricular function, as we've said, individual end organ functions. Vestibular neuritis, we can identify superior or inferior vestibular neuritis. We can look at the effects from Meniere's disease in VEMPs. So we have something called VEMP tuning. So if you have a preferential response to different frequencies of stimulation, then that can indicate Meniere's disease. We can see third window and superior semicircular canal dehiscence. So there's a very strange sort of phenomena that happens where you have very large VEMP responses or a very low VEMP threshold in the case of third windows. And that's because additional stimulation occurs with that fistula in the semicircular canal. Again, we can obviously measure saccular function individually as well. So we can look at the superior vestibular nerve. We can see vestibular schwannomas. We can identify which branches that they're on as well. And of course, the inferior vestibular nerve with the saccular function. So we can put together all of our different vestibular end organs and sort of piece together the puzzle that occurs in the vestibular system. So I said earlier, we can be a bit like Sherlock Holmes and like the investigator, and we can really sort of identify exactly where those conditions are occurring. And by combining those end organs together in different assessments, then we can really understand the peripheral vestibular pathology that occurs. So I have a sort of 3 steps to doing this. So first of all, we can look at semicircular canal involvement. Then we can look at utricular involvement, and then we can look at saccular involvement. So obviously the semicircular canals are on the superior and inferior vestibular nerves. If we then look at semicircular canal and utricular involvement, then we're looking at the superior vestibular nerve only. If we look at semicircular canal and saccular involvement, then we're looking at the inferior nerve only. So altogether, we can, if we look at all 3 of those systems, then we can look at all of those branches together. So let's have a quick look at a little case just to sort of give an example of how this might work. So this person had a sudden onset of dizziness, and they described true rotational dizziness, which resolved over 48 hours. So they had a spinning sensation, which got better over the course of 2 days. However, they continued to feel unwell for days afterwards. They spent the first 48 hours lying down in bed, and then they were able to move around the home, and they were able to increase their activity over the next week. They still feel briefly dizzy if they move their head quickly, and they've returned to work, but they've limited activities. So this might be a very sort of common case presentation that you would get with any of your dizzy patients. Essentially now they're back to normal, but with reduced activity. So maybe sort of only turning very slowly. They might find it difficult when wrestling with the traffic in Jakarta. They can't sort of turn their head quickly. So how would we go about this in this sort of forensic approach? Well, we do some assessments because we want to understand exactly what's going on. So if we analyze their left ear first, in this case, their C-vemp was normal and their O-vemp was normal. So otolith function, we can say, is normal. Under VNG, they were normal, both left and right. And in the Dix-Hallpike test, they were normal as well. So we can rule out BPPV, and we can say that central function or central dysfunction isn't indicated in the VNG test. Caloric, the left ear was abnormal. And in VHIT, the lateral left was abnormal. The route, so the right anterior, left posterior test was normal, and the left anterior, right posterior test was normal. So we've got 2 sort of abnormal results here. Let's see what we think here. So if we look at left hyperfunction, analyzing the semicircular canals, well, the anterior and the posterior semicircular canals are fine. Those RALP and LARP VHITs were fine. but the lateral semicircular canal has dysfunction. Utricular function was fine, that O-vent was fine, saccular function was fine, C-vent was absolutely fine. So we can say we've got a left lateral semicircular canal hyperfunction. So this is an isolated disease on the left lateral semicircular canal. Now you might say, okay, what does that help us understand? It means that now we can generate a rehabilitation program that focuses on that end organ only. So if we want this patient to get better, to improve back to normal function, then obviously we need to rehabilitate them. By doing all of these assessments, we've identified the exact organ that's not working properly. And that means when I give them exercises to do, I'm actually targeting that exercise on the end organ that's not working properly. So something which might seem ridiculous when I give this as an example, but if you speak to a physiotherapist and say, right, I've had a broken arm, my left arm was broken, and I need to get that back to normal strength. I need to, get back to normal activity. Your physiotherapist would focus all of the rehabilitation on that left arm. You wouldn't get a physiotherapist that would say, okay, you've got a left broken arm, let's get you doing squats and doing these, right? Because as a patient, I've only got so much energy and so much time that I can commit to my rehabilitation. If I'm trying to make this arm better and I'm doing this, then I'm wasting a lot of my energy and time by exercising things that don't need to be exercised. So your physio would say, let's just focus on activities on that left arm. The same occurs really for a vestibular patient. It's very common that a vestibular patient who's spontaneously improving, just given some generic exercises to do at home, and hopefully they'll start to feel better. But it's a very untargeted approach that doesn't really help them to feel better quickly and effectively. So by doing those tests, we can really understand what was wrong and how we can improve it. Let's have another quick example here. So this patient, another sudden onset of dizziness. And again, they describe true rotational dizziness resolving over 4 hours in this case. They've experienced symptoms in their right ear. So describing an odd sensation in the ear, so some ringing and some distortion to the hearing since the dizziness occurred. They've experienced 5 episodes of this since, and they feel worried about the unpredictable nature of the symptoms. Some dizziness is triggered with head movement. So sort of a very similar onset, but with a different condition throughout. So let's do some assessments and see what we've got here. So for this patient, the left ear, obviously where they had all of those ear-related symptoms. O-vent in the right was abnormal. C-vent in the right was abnormal. And ECOG was normal. In DNG, normal responses, so right and left were normal. Dix-Hallpike test was positive for BPPV in the right ear. Caloric response in the right was abnormal. And the lateral V hits in the right were abnormal for all semicircular canals. So lateral, route, and LARC were all abnormal. So we've got quite a sort of big set of results here that are all kind of spread around the ear and acting quite differently and quite strangely. So do we think they've got right hyperfunction? Well, let's look at the semicircular canals. None of the semicircular canals are working. The utricle not working properly, and the saccule not working properly. So case presentation that might have seen something like Meniere's disease, perhaps. When we actually analyze it and look at it, then we've got a right hyperfunction of all end organs and a right BPPV that's overlaid with that. So we've got a labyrinthitis with an overlaid right BPPV in this case. So presented really seeming like a Meniere's attack, and then when actually analyzed, something quite different. I suspect if this patient arrived to their general practitioner, to their family doctor, they would have been told you've got Meniere's disease, given some beta histines and sort of sent on their way. And that would be a very normal sort of occurrence for this patient. And then very likely they'd end up in one of our clinics in about 4 years' time, having not had any recovery of their condition. So by using this sort of forensic approach, we can really understand the site of conditions that have affected the peripheral vestibular system. So this is a very handy table, and I'd advise you, and this should be in your handouts as well. But by looking at the pattern of normal and abnormal results throughout all of these tests, we can actually identify whereabouts any of these vestibular conditions are occurring. Combining that with case history, and then we really understand the disease the patient may have, the additional conditions they may have that are overlaying, but can really help us target treatment and rehabilitation afterwards. So a question that I always get when doing this kind of talk, and the reason I put this in here is because I get this question all the time. So how do I then actually choose which of these tests that I do? Because I'll be honest, it's very easy for me to talk about all of these different tests and how they're also useful. But in the real world, we don't have all of this equipment. We were talking just this morning about the equipment that we do have and that we don't, and trying to put these things together. So choosing the diagnostic toolbox really relates to your clinic. So where are your patients coming from and why are they coming to you? So are they coming from the family doctor or from the emergency room? Can give you a very different set of needs that you have for your patients. Some of this equipment takes up quite a lot of space. And so do you have the space that you can dedicate to this equipment? Because installing it, you know, although I was able to fit all of this equipment in my suitcase and fly it halfway around the world, it'd be very difficult to set up a clinic that is mobile. Most times we would have fixed positions for a lot of this equipment. How extensive do you want your service to be? Do you want to be somebody that's testing absolutely everything, or are you targeting to a particular population? Will you be doing diagnostics as well as rehab? So do you need to do all of the tests that indicate where rehab needs to be, or do you just need to triage patients and find out the ones with something nefarious versus something that needs rehabilitation? If you're diagnosing particular conditions or diagnosing or triaging patients in particular ways, do you have options to refer them on to go and see another specialist? Do you have physiotherapists that you can work with? Do you have neurologists that you can refer your patients to? If you get a patient that is actually more suited to somebody else, can you refer to those patients? And then, of course, thinking about budget as well. That's something that's very important when deciding what equipment you have. Putting all of these things together allows you to sort of understand what equipment you actually might need. So essentially, by going through all of that process, understanding what you need, you can then decide whereabouts on the sort of specific accuracy you want to be. So of course, using vision only is not particularly accurate. Video Frenzel is very, very accurate. VNG, even more accurate, and so on. Okay, so that's our first one for the day. So we're a little bit behind time as we are. Are you happy for me to jump straight into the next session, Doctor? I had Ocular Counter Roll and BEM, if that's okay. Yep. Then we'll have a break. Right. So we do have an opportunity for questions in the agenda. So I will, because of that, we'll go straight into our next session. And then I promise we'll have a break at 10:45. We'll have our break, and I'll try and get us through the agenda as effectively as possible. So we've looked at all of the different assessments that we can do as a whole, but let's get a little bit more specific now and start testing those otolith organs specifically. And I'll give you a lot of detail here about how we do that and why we have different assessments for that. So here you can see someone who's very attractively set up with all of the EP systems. So they're obviously having an ocular vent done here. Okay, so just a very quick breakdown of what we're going to cover in this session. So otoliths respond to vibration and to head tilt. So we can either shake an otolith organ or we can tilt it. And that's because the otolith organs are actually always under stimulation because of gravity. Okay, if you think about the orientation of the otolith organs, there's always some sort of stimulation on them. We have ovemps and cvemps for the saccule and utricle. We have vemps and OCR because we want to sort of look at these two different systems of stimulation, the sustained versus the transient stimulation. We can look at the effectiveness of these different tests. So OCR will compensate whereas we don't have any recovery of vemp responses in disease. Although we must say that the vemp, although it's the older test, is actually the gold standard as it has distinct patterns in different pathologies. Whereas the OCR is functional assessment, which is very helpful, but it is binary. It's either there or it isn't. So we'll have a look at that in some detail now. So we are obviously looking at the otolith organs that occur in this little bit here. And in there, we have our utricle and our saccule. So just a very quick overview then of how the anatomy and physiology actually work. So embedded in that gelatinous sort of layer of the otolith organs, we have the otoconia, so the little crystal. And obviously those little crystals are the things that fall off and cause BPPV. But what's quite important about those otoconia is that they're heavier than the endolymph, the fluid that surrounds them. That's why BPPV responds to head movements with respect to gravity. So all of the head movements that we do with BPPV testing are actually putting the canals into a plane where the otoconia will sink to the bottom. So those otoconia being heavier than the endolymph is actually very useful to us. The gelatinous layer is the same density as the surrounding endolymph. So that gelatinous sort of layer, if you think about it, is sort of suspended in that endolymph. Okay, so it's actually floating. Although it's fixed to something, it's floating all the time. So even when we're standing still, the gelatinous layer isn't sort of forced at the bottom. It's not forced down all the time. It's sort of floating and sort of bumping around ever so slightly all of the time, which means that it's always responding. It's always being stimulated with respect to gravity. So that's very, very important. And the hair cells are then embedded in that gelatinous layer at the other end. So we have this gelatinous layer with this heavy sort of set of otoconia on it, but it's floating. So if it's always under stimulation, then you might assume that we'll always be feeling like we're moving and always sort of having some kind of stimulation from our vestibular system. But what's really important to understand about the system is that these hair cells, yes, they're always stimulating and always firing, but it's analyzed differently to the hair cells in the cochlea, for example. We all understand and know that the cochlea is tonotypically organized, so low frequencies and high frequencies at different ends. So the stimulation of those different hair cells refers to different frequencies of sound coming in. For the in the cupula, we obviously have movement of the hair cells in the cupula, and that is that responds in respect to different head movements in different directions. So if we're doing this, then only the horizontal canals are firing, and if we do this, then only the posterior and anterior canals are firing. But if all of the hair cells are always firing in the otoliths, then we would expect to be dizzy all of the time, essentially. But the way that the brain actually analyzes the hair cells firing is actually in a pattern of firing. So we actually learn different patterns of movements that occur. So just sort of a general firing that occurs all the time, our brain understands that pattern as no movement. Although there's firing and essentially stimulation, the brain says, no, I know what that means. That means no movement. And then when I do this, there's a different pattern of hair cell stimulation that occurs. And that gives us the way that our brain actually understands otolith function. So it's extremely complicated. And actually how those patterns refer to different movements isn't known at the moment. And it's probably different for everybody, depending on your own anatomy. So what we thought were very simple organs are actually extremely complicated. So linear force moves the otoconia and pulls the gelatinous membrane with it. So if I do that, you can sort of imagine that otoconia does this and then catches up. So when that happens, it causes a decrease in firing in some cells and an increase in firing in other cells. So here's an example of that happening. So the utricle will shear under horizontal acceleration, like if we move in a car. So that sort of the shape of the utricle will move as we go under horizontal acceleration. And the pattern of that activity that's caused the deactivation and activation of underlying hair cells, that's recognized as a particular pattern of movement, which is then recognized as a particular type of movement that occurs. Obviously, the utricle not just responds to translational movement, but also to head tilt as well, because now it's being changed, its position is changed in respect to gravity. So the gravity will affect it ever so slightly different. The saccule will actually shear, will move in response to vertical acceleration. So if you go in an elevator, then a different pattern occurs. If you have a disease of the otolith organs, then there's very little compensation that occurs. There's also no comparison of the left and right sides for the otoliths. So your brain doesn't go, okay, if the left was moving like this and the right was moving like this, it doesn't compare the two responses together, not like it does with horizontal movement in caloric stimulation, for example. So the utricle, as we've said already, is attached to the superior vestibular nerve, and the saccule is attached to the inferior vestibular nerve. There are actually a few strands of the superior vestibular nerve that are attached to the saccule, but it is mostly just the inferior vestibular nerve that is attached to the saccule. So I kind of lied to you earlier when I said it's just the inferior nerve. There is a little bit of the superior nerve as well, but it's only ever so slight. So really it's dominated by the inferior vestibular nerve. Otolith activation generates eye movements, and that's called the otolith ocular reflex. Obviously, we're very familiar with the vestibular ocular reflex, the VOR. That's to those rotational movements. But the eyes do move with respect to the otoliths. And then we also have postural control mechanisms, so the righting reflex. So if I'm tipped sideways, then my spine will compensate. But my eyes will also compensate if I'm tipped sideways. When I move my head like this, the whole world doesn't move like that. It stays upright, but because my eyes are compensating for that. So there's head tilts, and those movements with respect to gravity cause activation of the otoliths, but we can also vibrate them as well. So if we shake the otoliths, then we can generate what's called a transient response that occurs. We can generate also a sustained response, and that's a head tilt. If you think about the difference between tilting your head, where it's being held in position, so that movement has to continue to occur, the stimulation has to continue to occur for the eyes to be held at that rotated position. But a vamp response, so shaking the otoliths, vamp response is like tapping the otoliths over and over again. So it's transient. It's sort of tap, respond, tap, respond, tap, respond. Whereas a tilt is, yeah, response is still going, still going, still going, still going. So you have these two different transient and sustained systems. So we can test the otoliths in two different ways, with vamp and with OCR. And so in this way, we're actually testing the two different responsive systems that the otoliths have. By using the vamps, then we're testing the transient system of the otolith. And by using the OCR, then we're testing the sustained system. And so that's why we have these two different tests of the vestibular system. So vamps, vestibular evoked myogenic potential. We've looked at them briefly already today. So the O-vamp, looking at vestibular, looking at the utricle, and the C-vamp, looking at the sacral. Again, very useful to record vamps because it helps us with this pattern of analysis of the vestibular system. Let's look at how the C-vamp actually happens. We've already looked at the pathway today. So how do we actually record it? Well, we use an electrode montage that you can see here. So we have the brown on the low forehead. We have the right sternocleidomastoid muscle here. And we have the left here. And then we have on the clavicle joint, then we have the active electrode. We would actually say, so this picture isn't actually very good, but it's useful to have this picture here because this is a common mistake that occurs. You can see that the right electrode is actually much higher up on the neck than the left electrode. And when we're doing vamps, we are actually comparing the strength of response from the left compared to the strength of response from the right. But the sternocleidomastoid muscles have, they're not sort of just one big muscle all the way along, sort of narrow at the top, widens, and then narrows again. So that means that the strength of response we can record actually depends on where you put the electrode. So if you put one electrode on the widest point of one side, and then one electrode on a narrower point on another side, when you compare the responses, then the one from this right side that's narrower will be a smaller response. And that doesn't mean that the right side's not working properly. It just means that the recording technique was poor. So really what we should have is a very horizontal position of those electrodes. So that's very important to do. And then to get the best quality response, we want to get the biggest response from the muscle as possible. And so we're looking for what's called the bulb of the sternocleidomastoid muscle. There's a few different ways of finding it. There's this technique, because it's roughly 3 fingers width from the bottom of the ear. But obviously, that is different for some patients with long necks, some people with big fingers, and some people with small fingers. So I'd actually always recommend having your patient turn their head, really exposing that muscle, and then using your fingers to squeeze along the muscle until you find the widest point of the muscle. And I'm very happy to see lots of you doing it yourselves, because you can really feel that point where it really widens out. At the top, it doesn't seem to get particularly wide, or it's a little bit there. But then as soon as you can feel it when it starts to get narrower as you go down, and then it really starts to disappear. So it's that point there where it's really nice and wide. Some patients have got very large necks with lots of fat and tissue around them, so they can be a little bit tricky to get those muscles to come out. So there's different position techniques you can use. You can either have them sitting in a chair, trying to put their chin on their shoulder, and it really comes out, or you can have them lying on their back so lying supine, and then lifting their head up, and that exposes both of those muscles at the same time. That is the best way to really get both of those muscles really contracted. So people that are very difficult to find those muscles, lie them down and have them sit up. But that position is very difficult to hold for a long period of time. Okay, so lots of your patients won't be able to do that for a particularly long time. So having them sit and turn their head is easier for most patients. So you can see here that this is a head turn, but then here we have them lying on the back, sitting up and turning to one side. By turning to one side, you relax one muscle and you contract the other. They turn the head to the opposite direction, opposite to the test ear. So if we're testing the right ear, then they must move their head to the left. That exposes that muscle for us. We present a loud stimulus, and that will generate a response that we can measure. So loud stimulus, put the patient in the correct position. We need to make sure that the muscle is contracted enough. And so this system, you can see, has a monitor of the amount of contraction of the muscle. And that's really important. We'll look at that more in detail. But if there's not enough contraction, then it will just be in this area. When we have enough contraction, it's up here. We want the EEG to be low, so as little electrical noise as possible. And then you'll start generating a response that looks like this. Initially, with the first few presentations, there's a lot of noise and a lot of things going on. But as you do repeated presentations, so about 500 stimulations, then you can average the response together, and you end up with a response that looks like this. Okay? So remember, this is an inhibition of the muscle. So we start off, the response starts off by a contraction and then a big drop in response there. So it's always contracted, and then to release that contraction actually sort of squeezes a little bit more and then really releases. So we see this big drop in activity before returning back to that base point, to that baseline. And then what we do is we measure the amplitude of response on one side, and we compare it to the amplitude of response on the other side. We can also look at the latency of the response. So in time, we can see where that P1 and the N1 occurs. So P1 is that peak here, and N1 is that drop. So latencies are affected by the position of the electrodes, and they're affected by the length of the muscle as well. So latencies themselves don't give you sort of a normal or abnormal response. So comparing the latencies across lots of different patients isn't an amazing way of looking at normal or abnormal, but it does help us identify the event itself. So we expect P1, this peak here, to be about 16 milliseconds after the stimulus. And then N1, we expect it to be about 25 milliseconds after the stimulus. And then, so this was all recorded on this equipment here. And you can see that there has this little darker zone at the bottom, which just gives us the essentially where we're expecting the response to be. Anywhere within that sort of point, then we know that's normal. I do compare latencies from left ear to right ear, as long as I've got my electrodes in the correct position, because what I might be able to see is some neuropathy on one side or something like that. But what I'm really looking at is amplitude. Amplitude is our true sort of understanding of the vent response. So we're expecting it to be between 50 and 300 microvolts. So this is a very big response in the world of EP. So much bigger than we would see with an ABR, for example. And that's because this muscle is quite big. What I'm really looking at is the asymmetry between the two responses. So I compare the left and the right responses, and I generate what's called an asymmetry measure, so a percentage comparison between the two. And so we're expecting them to be about, to have a difference of no more than 36%. more than 36% asymmetry, then I'm worried that one side is actually significantly smaller than the other side. What's really important, though, is that the amplitude of response is dependent on how much the muscle is contracted. So if you measured my vent now, I would have a small response. And then if you measure it now, I'd have a much bigger response. So it's really important that your system can understand how much contraction was on the muscle when the response was generated. And so in this system, that's what this is doing. And it analyzes the amount of contraction on the muscle. And then you can actually normalize it. So you just press a magic button and it will change the amplitude of the measurement you've taken in respect to the amount of contraction on the muscle. So that's really important because we're only going to do a left and a right at one time. So we only measure the right, and then we have a break, and then we measure the left. That's fine for someone who's young and fit and healthy. They can keep that strong contraction over the period of the whole appointment. But someone who's not so healthy, someone who's a bit older, will be able to strongly contract the muscle one side, and then they'll be tired, and then they'll only be able to contract the muscle a very small amount next time. So we need to be able to normalize the contraction, and we need to be able to do that digitally afterwards. So those asymmetry values are only relevant when you can ensure the correct contraction of both sets of muscles. Okay, looking at the OVEMP, so we've already seen the pathway today. And this is one particular montage you can use. So again, we're looking at the inferior oblique muscle. So the inferior oblique is just about here, and it's just under the surface of the eyelid, and it's just outside of center. So not in the very middle of the eye, but just outside of center. So that's one montage that you can use, or here's an alternative montage where we have the active and ground electrodes on the forehead. You can also put the one electrode on the chin as well. Obviously, it really depends on the patient that you've got and normative data in your clinic. So in some countries, lots of men will have beards. And so being able to put an electrode here is very difficult because you can't get it to sort of firmly sit over the beard. And your patients aren't going to shave their face just for you to do this test. So having alternative montages is a good idea. But using one montage in your clinic is a good idea, because then you can generate normative data for your clinic. So picking a technique and sticking with it is very important. The next thing that is essential for OVEMPs is for your patient to be looking up the whole time you're doing this test. And the reason for that is that by looking upwards, by turning the eye like that, the muscle comes from underneath the eye to in front, because you're literally pulling the muscle up. And so you can actually test this yourself. Now, you put your finger just under your eyes, on your eyelid, and then look up, you can actually feel that muscle just sort of appear. And so what we need is for that muscle to be as close to the surface of the skin as possible, because it's a very small muscle, which means the electricity from it is very small. And so putting it closer to the surface of the skin means that we can record it more easily. Okay, it's only to make recording easier that we make our patients look up, but it's essential that they look up because the response is so small. Again, we present a loud stimulus, and in a very similar fashion, we end up with a response. The CVEMP, remember, 50 to 300 microvolts. The OVEMP is about 7 microvolts. It's tiny, absolutely tiny. And so with all the other activity that's happening on the face, that response being so small, we need the response to be as big as possible. So we really need that muscle to be at the surface of the skin. Latencies are slightly different as well. So now we have N1 at 10 milliseconds and P1 at about 15 milliseconds. Again, remember, this is now an excitatory response, not an inhibitory response. So you have the N before the P this time. Yep, so it's down, up rather than up, down. So they should be sort of, yeah, opposite to each other. Much smaller amplitude. And this time, the asymmetry value that I use is 34 to 35%, so a slightly smaller asymmetry value that occurs. So interpreting these, the most important thing is the amplitude and the asymmetry that occurs. The second most important thing is latency. People that have a lot of experience doing ABRs, for example, can be a little bit obsessed with latency. And it's super important to look at latency with ABRs, like neuro rate studies and those kind of things. Latency is really, really important. Latency is not so important in VEMPs. And that's something that I do want to stress just a little bit. Don't get hung up if your latencies are 3, 4, even 5 milliseconds out of norms. That could just be your patient that you have in front of you. Let's have a look at some pathologies that occur and how they look in VEMPs. So VEMPs are so useful for semicircular canal dehiscence. And really, if you've got a patient whose history indicates semicircular canal dehiscence, if you can do a VEMP, then you'll have that patient diagnosed in 10 minutes from them walking in through your door. It's so easy because the CVEMP response is so big on the side where a semicircular canal dehiscence occurs. So when you have this sort of fistula, it changes the amount of pressure in the inner ear, and that actually means that when you stimulate the semicircular canals or the saccule, then it changes the amount of pressure, and so it changes the amount of stimulation that occurs on the saccule when you send a sound in. So what you see is you have these huge responses that occur on the side where the semicircular canal dehiscence was. What's funny is if you test the side that's got the semicircular canal dehiscence first, you see a big VEMP response. But you don't know at that point whether that's just they've got a big VEMP response or if it's because of the semicircular canal dehiscence. And then you test the other side and it seems relatively absolutely tiny. And so then you know where it actually was. But not only do you see this very big response that occurs at normal stimulation levels, so at around sort of 95 here, that's quite a big response. But what you also see is that the threshold becomes very, very low. You can still get a VEMP response in some cases down to about 70 or 60 dB of stimulation. You should never get a VEMP response down at 60, definitely 70, no, 80 even, you'll struggle to get a response normally. But in the cases of semicircular canal dehiscence, then you do get this, you get these strong responses at very low stimulation level. Whereas on the other side, you can see here, we've got normal responses at 100 dB. But obviously this is much smaller than what's going on here because the scale is so big on this side. So you can very quickly identify that. We can look at otolith involvement in bilateral vestibular loss. So not very common, but bilateral vestibular loss, you should have no otolith function whatsoever. So in this case, you can see essentially two flat lines where there's no otolith function at all. In the presence of Meniere's disease, you can actually see what we call VEMP tuning. So some of these responses are at different frequencies. So if we stimulate, normally we stimulate at 500 hertz, but in the cases of Meniere's disease, if you increase that to 1000 hertz, like you can see here, this response becomes much bigger. And so there's because of the sort of the pressure that's in that inner ear system, more pressure, it actually responds to the higher frequencies more effectively than to the lower frequencies. So you see, it's called VEMP tuning, responds to higher frequencies. So this left ear is normal. There's no Meniere's disease. So we've got the biggest response at 500 hertz. And then at 1000 hertz, it's a smaller response. And this right ear is abnormal, where we have a response at 500 hertz, but at 1000 hertz, it's much bigger. So this is a case of high drops in the right ear. And then you might even get an isolated saccular condition as well, where you'll have a nice strong CVEMP in one side and then no CVEMP whatsoever on the other side. Not super common for individual otoliths to be completely dysfunctional, but it can occur with sort of isolated ischemic attacks and those kind of things where the where the blood supply can be limited. Okay. In order to get on time, I'm going to skip the case example, but you can work through that on your examples that you have in front of you. But essentially, it's going through the same process that we went through earlier of identifying where the site of lesion actually is. So you can see I use this table a lot because it helps me really understand what's going on with particular patients. But that's a really nice example. If you get the time in the next couple of weeks, just to run through that, see how the case history sort of generates a particular condition. So we have some massive benefits to doing VEMPs. It's a perfect way of doing differential diagnosis for semicircular canal dehiscence. Really good for peripheral end organ screening, especially if you combine it with VHIT. Then we've got all of the vestibular end organs covered. We can test the separate otoliths, and we can test them both individually as well, so without generating response from the other side. And there's no compensation in VEMP. So as the patients, as they centrally get used to having a vestibular condition, they might perform well. So what's good about VEMPs having no compensation is, if you see a patient 2 years after their vestibular insult, then you will still see and the VEMPs are absent. So you can still actually diagnose what they had, even though the condition isn't so bad because we're 2 years down the line. However, there are of course, some challenges with VEMPs as well. It's very difficult to test VEMPs in some patients, especially elderly patients, especially the C-VEMP, because they're unable to hold that contraction for a long period of time. Although it doesn't take a long time to do VEMPs, it can be difficult for some patients to do it. We're using a non-physiological stimulus to generate this response. So the otoliths are not designed, they're not supposed to respond to vibration, really. That's not what they're there to do. But we're using vibration to stimulate them. So it's non-physiological. It's just not the way that the otoliths actually work. This does mean that we get no compensation, which can be useful, as we've said earlier, but also can be frustrating because if you're trying to demonstrate compensation, then you can't use VEMP to demonstrate compensation with a patient. Results are highly affected by the parameters or the protocol that you use in your clinic. So it's actually very difficult to compare your VEMP responses that you've collected in your clinic. It's very difficult to compare those with somebody else's VEMP responses that they've collected in their clinic. So sharing information across clinics can be difficult. Saying to your colleague, oh, I got this strange VEMP response. What do you think? They'll say, well, oh yeah, in my clinic, that means this. But that might not be the case in your clinic. So your protocol can make a huge difference. Even your, as we said earlier, the montage that you use of the electrodes can make a big difference. And I wouldn't recommend doing this in patients with tinnitus. We're using a very loud stimulus. And honestly, you know, if I've done days and of workshops with VEMPs in universities and things. Having a VEMP done on you more than 3 times in one day is really annoying. It really is just too loud. And so when doing demonstrations and workshops, I say maximum of 10 minutes per person before doing it on somebody else. And so tinnitus patients especially, we can't do VEMPs not with an auditory signal anyway, because it's just very triggering for the tinnitus. You can use head vibrators, so using like a massager to vibrate. But again, that's still actually a vibration, still a sound stimulus, and that can be quite triggering for a lot of people with tinnitus as well. Using bone conduction or a vibrator is very useful in people like me who've got a conductive hearing loss. Because I've got a conductive hearing loss on my right ear. If we use insert headphones and send a 97 dB sound into my right ear, by the time it gets to my inner ear, it's only about 40 dB, and that's not going to generate a VEMP response. So using bone conduction is important for VEMS. That has brought us to time for a coffee break. And then after the coffee break, I'll do ocular counter roll. And then we should be, yeah, then we'll start to get back on track with the agenda, but I'll try and get us there. But yes, if you're happy, then we'll break for coffee.
Thank you, Jack, for a very nice presentation. And because I mean, the time is running very fast, and some of us have to go to Bandung for tomorrow's workshop. If you don't mind, maybe just let take all the coffee or tea and snack here, if you don't mind.
Right. Yep.
But of course, because you have to present it, you have to take it first, and then that, you know, you can. But just would like to actually, if you don't mind, let the take on.
Of course. Coffee. Yeah, that'd be perfect.
While listening to your. So
that works for me.
Yeah.
Coffee's a very good way of listening to me. I think I'd recommend it.
Because it saves time.
Yes, absolutely.
Bisa dibawa ke dalam. Oke, lalu untuk sejawat yang online, barangkali dari presentasi yang sudah dikemukakan oleh Jack, sudah bisa mulai menulis di chat supaya nanti bisa kita discuss pada saat question and answer. Terima kasih.
Saya sebagai dokter ada yang mau nanti setelah break lunch
Halo?
Cek tes 1.
So, all right, please continue with the next.
Yes.
Untuk sejawat yang online, silakan bisa tulis pertanyaan di chat.
Okay, fantastic. So hopefully you've all had a bit of coffee and you've got your snacks, so we're all lots of energy, which will take us through to lunch. I'll try and be as energetic as possible as well, though the jet lag is starting to set in now, but we will get there. So we've looked now at VEMPs and their utility for otolith function. But now I'd like to look at something that is really quite new to the world of vestibular medicine, which is the OCR, or the Ocular Counter Roll test. For your handouts and what you've got there, and also just for general reading and learning, I would recommend this paper by Ian Curthoys. It really is a just a really important document that helps you really understand the anatomy and the physiological processes that the otolith organs go through. And really it helps you understand the difference between the VEMP and the Ocular Counter Roll assessments. I'm going to do my very best just to briefly outline it now, and because it helps us understand why the Ocular Counter Roll is still important in the case of, even though we've got VEMPs as well. So the two otoliths are obviously orientated in different positions with respect to gravity. So the saccule sort of sitting on the side in kind of this vertical position, and then the utricle sitting in this kind of horizontal position. If, however, we look at either one of these two organs, then we have to really understand how the hair cells and the otoconia are sort of arranged on these organs. And so we've already discussed the importance of the otoconia being sort of embedded in the gelatinous membrane at the top, and also the importance of the hair cells being embedded in the bottom of that gelatinous layer. What we also have, however, is this kind of this line that sort of splits the organs down the middle. And what's really interesting about this line is that either side of the line, the hair cells are actually orientated in a different angle. And so on one side of that line that sort of splits them, the hair cells are orientated so that essentially all the time the larger hair cells, the kinocilia, are pointed towards that line that sort of sits between the middle. But it does mean that as you tip the otolith organ in one direction, one half of the hair cells will activate and the other half will inhibit. And this earlier is what I was talking about with that sort of pattern recognition that has to occur. Because with one tilt, half the hair cells are going in one direction and half the hair cells are going in the other direction. So really we must think of these organs as a differential receptor, and the organization of the hair cells is actually analogous to the organization of hair cells on the retina, where you have a density of receptive cells in the very middle, and then fewer receptive cells on the edge of the organ. And so where you have lots of cones centralized, sort of concentrated on the fovea, specialized to detect fine detail, but many more receptors on the rest of the retina, but they're obviously having to focus on a much larger area, which means that you have a higher density of focus in the middle than you do around the edge. The same actually happens in the otolith organ, where we have high frequency stimulations that are actually received, and the reception of a high frequency stimulation happens right around this central line. So essentially, the VEMP response is generated by these hair cells that are right in the middle of the otolith organs, whereas the sustained sort of low frequency stimulus is actually generated by all of the other hair cells that are around the edges. So we said earlier, we have a transient system and a sustained system. They're actually being generated by hair cell activation at different places on the otolith organ. So we can actually have conditions that may affect different parts of this system. And so you might see patterns of VEMP versus ocular counter roll where one will be good and the other will be bad, which could indicate some sort of disease of different parts of the otolith organ. Although that's not borne out in any literature at the moment, it's what we can infer from the anatomy that we see. So we've looked at that transient system already in VEMP. So now we should look at this sustained system, this low frequency stimulation that occurs, which is really due to the gravity inertial response. That is, if we tilt our head, we get a particular type of stimulation that occurs. And that's what we see in the ocular counter roll. So we can test this transient, this sustained system with the ocular counter roll, SVV, so static SVV, off-axis SVV, and linear translation as well. So the ocular counter roll really is the newest of these tests. It's very simple to do in clinic. You only need a small amount of equipment, whereas doing SVV, you need quite a lot of equipment, projectors and goggles and all sorts of things to go on. Ocular counter roll is very easy. And what we are looking here is for the response of the eyes to a head tilt. So as I said earlier, if I tilt my head to the left, I'd expect my eyes actually to twist and turn in the opposite direction, keeping the world vertical and horizontal as it should be. So as we tilt, so the actual movement that occurs in that portion there is called the dynamic OCR. And that's the eyes responding as I move my head is actually generated by activity from the semicircular canal and the otolith organs. Obviously, there's a bit of rotational movement going on, so the semicircular canals do fire and send the eyes off in the other direction. But as the head tilt is sustained, so we're no longer putting our head into motion, that means the semicircular canals are no longer actually firing, but the eye torsion still occurs, which means for the eye torsion to be sustained, then the otolith organs must be continuing that stimulation. They're continuing the response. They're holding that in place, and it's primarily the utricle that is driving this response. If you think about the orientation of the utricle and the saccule, as we tilt that way, there's a lot more change that occurs to the utricle than to the saccule. It has a gain value of 10 to 25 degrees. What we mean by that is if I tilt my head by 30 degrees, then the eyes should twist by about 3 degrees to 10 degrees. So 30 degree of head tilt means 3 to 10 degrees of eye torsion. So what that means is what it isn't is 30 degrees of head tilt, 30 degrees of eye torsion. It's a small response to a large head turn. It's very easy to test this in clinic. You just need a set of V&G goggles. You need something for the patient to fixate on, so something for them to look at the entire time. Draw a circle on the wall or just have your V&G stimulus generate a circle for the patient to look at. This stops their eyes moving around and it stops convergence of the eyes as well. We have them looking, stationed about 135 to 150 centimeters away from the dot. If you're too close, the eyes will be turned in. So you need them to be turned out ever so slightly. Tilt the patient's head to the left and then to the right. And you hold them in that position for 30 seconds to a minute. And that's so that we can make sure the dynamic portion of the response has stopped, settled, and then we can measure for a period of time the sustaining of the eye torsion. And then we also want to keep it going just for a little bit longer, 30 seconds to a minute, just to make sure that that response doesn't diminish, because that might indicate some other sorts of pathology as well. So here's a very quick video of how that works. Really easy. You can tilt their head, and they're looking at the stimulus the whole time. Bring the head back to center, and then tilt it in the other direction. That is one technique. The other technique is to actually put your hands on the side of the patient's head and your elbows on their shoulders, and to move actually their whole body like this. And there's some discussion going on at the moment around the world as to which is the better technique. Obviously here, we do have some cervical input that occurs. So if we just tilt the head, then there's some cervical input going on. And so actually we might be getting cervical ocular reflex as well as just the otolith functions going in. So some people will advise actually to keep the head and neck straight and tilt here, because the spinal response, spinal ocular reflex is pretty much negligible. And so we'd expect them to, we'd expect the response to be generated by the otolith organs only. The next best thing really that I can think of is by putting someone in a TRV chair and moving the whole body. That'd be fantastic. But with the ocular counter roll being such a simple test, doing something so complicated like that maybe is not so relevant to do. So this is what we would expect to happen to the eyes as we tilt the patient's head. So this is a torsional analysis of eye movement. So we've got clockwise movement here and counterclockwise movement here, and that's from the left eye. And then from the right eye, we have the same clockwise and counterclockwise movement. So head straight up, there's no eye movement at all. Tilt the head to the left, dynamic nystagmus that occurs. And now the eye is actually being twisted and it keeps there. Now we've tilted the head to the right, dynamic portion, and now sustained eye torsion. So let's look at that in a little more detail with the pointer. So during this portion here, there was no head movement at all. So the eyes were straight, horizontal. At this point, we tilted the head to the left. So we saw a clockwise torsion of the eyes. This bit here, where we actually have nystagmus, and you might have noticed the eye sort of twisted like that, that was driven by the semicircular canals. So that was that dynamic portion. And then the sustained portion here, you can see we're at sort of about 4 degrees of torsion in the clockwise direction. So now that we know what's on the graph, let's just watch it again. So flat, flat, flat. Dynamic. Twist, 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 twist. Now that movement has stopped. Do that again. Where's my mouse? So let's run that again. Dynamic portion, semicircular canals, and now sustained torsion in the clockwise direction. So the head's tilted to the left, the eyes tilt clockwise in the opposite direction. And that's patient's angle. So I'm the patient, I move to the left. My eyes, as I see them, go clockwise. As you see them, that's going anti-clockwise. Yep. So it's from the patient's perspective as we describe these eye movements. This is something that's a big difficulty when reading the literature in ocular counter rolls, And even in BPPV and other things, isn't it? Especially with torsion, which direction is actually being described by the literature. And there are some leaders in the literature that describe it in one way and others that describe it in the other way. And I think everyone just needs to get in a room, have a cup of coffee, and agree over what they want to do. That would be nice, but when have people ever agreed? Not in my experience, does it happen very often. And now we go in the other direction, dynamic, now moving in the other direction, and sustained head tilt in the other direction. So really quite simple, I think, really easy to see on the camera. Seeing 3 degrees of torsion being sustained in clinic is actually really difficult to do. So having a system that can analyze that for you is pretty much essential for doing the ocular counter roll. What you might be able to notice if you just did this in clinic, looking at your patient, you might be able to see no dynamic nystagmus. And if you don't have the dynamic portion, you're not likely to have the sustained portion, but you might actually see slowly the eyes twist. But you're going to struggle to see it with the naked eye. 3 degrees of torsion is not very much. Here's an example of a pathology. So we have, there you go. So we have somebody here with, you can see when we tilt the head to the left, a very big response. So they're appropriately responding. And then when we tilt the head to the right, you can still see the dynamic portion. So that's being generated again by the semicircular canal. But then as soon as that's done, the eyes just come back to center. So it's not being sustained when tilting the head to the right. And you can see here, they had a left ovemp that was very strong, and then a right ovemp that really essentially isn't there, not very well, not very clear. And so they have a big problem with their utricle on the right-hand side. So we can see that in both the ovemp and in that ocular counter roll. So we said this is quite a new test. So obviously we need plenty of evidence to be out there about this. So can we actually detect dysfunction? So been a few studies now that have analyzed this, but I would refer you to 1 or 2 that I'll just do now. So this study by Otero, Milan and colleagues. So it looked at 14 healthy control, 12 patients with unilateral vestibular loss, so complete dysfunction of the vestibular system on one side, and 6 patients with a bilateral vestibular loss. They did VEMPs, C-VEMPs and O-VEMPs at 500 hertz of stimulation, and the OCR, they did 60 seconds of analysis in each position. Again, in clinic, 30 seconds should be fine, that's enough, but obviously they're doing a study, so they wanted just to really make sure that by doing 60 seconds of stimulation, they could really analyze it all. The VNG system, the visualized system, will record for as long as you want it to record, and you just advance the test. So you can do 30 seconds, 1 minute, 2 minutes, 10 minutes if you're crazy. You can do as long as you want. So the results correlated really well with the C-VEMP and the O-VEMP. So the false positive rate was pretty much the same with OCR, O-VEMP, and C-VEMP. Bilateral vestibular loss patients showed a reduced OCR in comparison to unilateral vestibular loss patients. So very small study, but it did show that those patients with bilateral loss had an even smaller OCR compared to those with a unilateral vestibular loss. The best ocular counter roll threshold to detect vestibular loss was 3 degrees. So that's why we say 10 to 25% of gain. So that 3 degree number was the best way of saying, right, if it's less than 3 degrees of torsion, then you've got a vestibular loss in that direction. Okay, so let's just summarize that, because that new test is interesting, but we need to sort of bring it back to first principles, really. So latest research has showed that otoliths respond to two different systems: that sustained system of tilt and the transient system, which we can generate with VEMP responses. So VEMP is a clinical test of the transient response of the otolith function, and the OCR, but also SVV, so static visual vertical, that's testing the sustained system of the otolith function. Having access to both allows us to really sort of drill down on exactly how those otoliths are working. It's sort of expanding the clinical picture that we have of those very small, very specific organs. But there's plenty more work to be done, I think, on understanding different patterns of VEMP versus OCR response. So that is everything that I wanted to tell you about otolith function today. So thank you very much. But I would really recommend that paper by Ian Curthoys for a really deep understanding. Yes, you have a question? Yeah, that's the perfect next question. And as with all good questions, I actually don't have an answer for that, because this is our new understanding of how those otoliths work. And so I suspect there is a difference, but how that is borne out in case history versus test result patterns, we just don't know yet. Even with rehabilitation, we don't know yet. What we do know, obviously, is that when rehabilitating patients, the VEMP responses do not compensate. So although they might rehabilitate in terms of their normal day-to-day function, if you test a VEMP response, then you can't demonstrate compensation. OCR, we may be able to demonstrate compensation, but it's difficult to say right now. It's a new test. So yeah, I'm trying to, maybe there's a study for you to to conduct. Great. Okay, so that is otolith function. Our next, it's another new test, saccadimetry. So let's start looking at saccadimetry now. Okay, so saccadimetry is a new testing paradigm, a new set of testing protocols in the world of VNG, vestibular nystagmography. I have already introduced myself, so I don't need to do this. Okay, so video nystagmography is very common in the world of vestibular medicine. It's our best sort of first process of understanding the central vestibular system by looking at saccadic eye movements, smooth pursuit eye movements, optokinetic eye movements, looking at caloric responses and all of those sorts of things. But it is absolutely the case that we miss some central pathologies when we look at saccade protocol. So saccadimetry is an extension of the random saccade test. So the random saccade test is where you have a stimulus the patient must follow. They sit still and they're only allowed to follow the stimulus with their eyes, and the stimulus will randomly jump left, right, but also vertically up and down. And we just ask the patient to look at where those eye movement, where the stimulus is going. We can then analyze those eye movements in terms of how accurate they are, how fast they are, and all of those sorts of things. But there are plenty of central vestibular conditions that are not well understood by looking at just the saccade protocols. So that's why we have saccadimetry. And really, this is where vestibular medicine starts to really sort of bump shoulders with neurology. And so those neuro-otologists that we have in the room start to get really quite excited, I think, about saccadimetry. So I think it's a really exciting sort of development that's going on. When we do saccades normally, we ask the patient to look at the stimulus that occurs. When we talk about saccadimetry, we call that process prosaccades. So following the stimulus with your eyes is a prosaccade. But we also do something called an anti-saccade in saccadimetry. And that is when, if the stimulus moves this way, we ask the patients to actually look in the other direction. That's called an anti-saccade. And we'll look in detail as to what that actually means and why we do that. But it's a sort of a new paradigm in saccadimetry. But we should look at prosaccades as well, because we have sort of developed and advanced what prosaccades are doing as well. So same idea, stimulus moves, the patient's eyes should move. They move by 10 degrees, so it's a fixed distance that the eyes are moving. And it's visually guided, so when the target moves, the eye should move as well. The difference in saccadimetry versus normal saccade testing is that we're going to put the patient through a lot more testing. So in normal saccades, you might do 5, 10, maybe 15 or 20 presentations. So they only have to move their eyes about 20 times maximum in clinic. In saccadimetry, we're going to give them 100 presentations of this stimulus. So it takes quite a lot longer to do, but that extended duration means that if the patient is going to fatigue quickly or quicker than someone that's normal, then we can see that fatiguing actually happening. We also in saccadimetry have extra interpretation measurements. So we're doing additional sort of measurements as well. So we'll look at those in detail. The anti-saccades, this involves the cognitive suppression of the prosaccade. So it is natural that if something quickly moves in our field of vision, that we look towards it. That's a natural thing that we do. Our bodies have evolved to, when something moves quickly, we want to see it. We want to see exactly what's going on. But if you're trying to focus on a particular task and something quickly happens, then it can also be useful to suppress the desire to look away. A very good example, something our ancestors might have had to do. There's a tiger walking towards you. You want to look at that. And then when a little bird moves in your peripheral vision, you don't want to look at the bird. You want to be focusing on that tiger the entire time. If we didn't have the suppression of prosaccades, we'd be looking at the tiger, the bird would move, and we'd go, oh, pretty. Oh, wait, tiger. Oh, something else happened over here. And so being able to focus intently is very, very important. But it's a cognitive decision. We must decide to look at the tiger and not at the bird. And so obviously with any cognitive process, being able to analyze whether that cognitive process occurs helps us very much with neurological conditions that might suppress that cognitive ability. So it gives us also greater insight into the saccadic pathways, because although saccades are normally spontaneous, the inhibition of a spontaneous pathway helps us really understand exactly how that pathway occurs. We're also going to look at the fatigability of this as well, and we'll also look at the advanced interpretation as well. So first of all, let's just look at the normal prosaccades that we would expect to see in clinic. So this is a VNG trace of a normal prosaccade that would occur. So we can see a yellow line. You can see this sort of the yellow line that's in here. That is the stimulus. That is the stimulus being center, moving to the left as it goes downwards. So downward movement is actually leftward movement. And then upward movement, that's moving to the right. And we can see here, this is a 5-degree eye movement. So 10 degrees up here, 5 degrees here. So the patient is tasked with following the stimulus as it moves from center to the left, stays at the left, and then it moves all the way to the right, stays at the right, all the way to the left, stays at the left. They don't know when the movement's going to happen, but they do know it will happen. And then we can look at their left and their right eye. So the right eye is the red trace, and then the left eye is the blue trace. You can just see that. And so we can see here, they're looking at the center dot. The dot moves, and then very briefly after, both of their eyes move together, and then both of their eyes stay on the target. Target moves. There's a brief period, and then the patient moves their eyes as well, and so on. So we can look at the latency. That's what this graph is showing us. This tells us how long it takes for the patient to see that the target has moved before they start their movement. That is latency. So that's this gap here. We can look at velocity. So how quickly do the eyes move? So once they've started moving, how quickly do they move? So that is this angle here is the velocity of eye movement. And then accuracy. Once they've moved their eyes, do they get to the target? Or do they don't go far enough? Or they might go too far. So you can have undershoot or overshoot. So you can have somebody that has a latency that's too long. So the target moves, and then they move their eyes too long. They're not reacting very quickly. You can have someone who might move their eyes as soon as the target moves, but actually they go very slowly to the target. And you might have someone with poor accuracy. So the target moves, and they don't move far enough, or they move too far. And any one of those, or a combination of those different inaccuracies or problems, can indicate different parts of the saccadic system that are not working properly. And my neurology isn't particularly good, so I can never remember the exact pathways that are not working properly, but I do have cheat sheets that help me sort of remember that. But really good neurologists will know exactly what's going on, which parts of the saccadic system are not working properly. So prosaccards are very common, lots of literature, lots of data, and we can generate these normative data values here. So for any patient of any age, you can compare them against other people of their age and understand what's going on. So we've got latency, velocity, and accuracy that we normally measure. When we do saccadometry, we end up with actually quite a few extra graphs that go on. And we do something ever so slightly different, which is we analyze the results separately for leftward moving targets and rightward moving targets. So you have a left experiment and a right experiment. And this is where I fall out with neurologists, because in neurology, a target that's moving to the left is a red line, and a target that's moving to the right is a green line. I'm an audiologist. Anything that happens in the left is blue. Anything that happens in the right is red. But neurologists, they're super clever. They know a lot about the brain. And when something moves to the left, it's the right side of the brain that's making that movement happen when the eyes move. And so the right is red. Ah, now it makes sense. Now it's the right side of the brain. And then when we do a right movement, it's the left side of the brain that's generating that right movement. And then they use green for left because it's not blue. No. But that's how neurologists work, and so we must work in that way as well. The first thing that a saccadometry experiment will do is count the amount of times the patient went in the correct direction. So if the target moves to the right and the patient moves their eyes to the right, they've gone in the correct direction. If the target moves to the right and they move their eyes to the left, they've gone in the wrong direction. And so we can look at what's called the directional error rate. So there are some people who will move in the wrong direction. They just can't, their spontaneous saccades are not very good. And so they're actually doing a volitional saccade. They're doing it on purpose. They've seen the target has moved, and they have to make a decision to move their eyes, and they sort of just react in the wrong way. So we analyze the directional error rate. We also analyze the velocity. So we measure how fast the eyes are moving. And we also measure the latency. So we measure how quickly the eyes are reacting. And we also measure the position, so essentially the accuracy of the eye movement as well. But we also measure the phase as well. So this is the eye velocity in terms of its position. So this is when when a saccade occurs, the eyes are not moving at the same speed the entire time they're moving. They actually start off a little bit slowly, speed up, and then as the eyes get towards the target, they slow down to stop at the target. Just like when you're driving a car, when the lights go green, you speed up, and then you get to your maximum speed. And then when you want to stop, because there's someone on a scooter that's just ran out in front of you, as they do in Jakarta, you want to slow down, but you can't instantly stop. Because if you instantly stop, you go through the windshield. So if you instantly stop, that's a bad thing. You slow down as you get to the target. The same thing happens with the eyes. So we can actually analyze the prosaccades with additional measurements. So position looks at the start position over time and then to the end. Velocity looks at the peak velocity, so the time to reach that peak velocity. The latency looks at how quickly they're reacting, and then the phase looks at the change in velocity over the time. So position, velocity, latency, phase, and directional error rate. Otherwise, it's exactly the same as normal saccades. We do also, however, have the anti-saccade protocol. So this is somebody doing an anti-saccade, but obviously we can't see their eyes in this video. So I've got an example here of exactly what's happening. So in the anti-saccade, first of all, the patient is looking at the dot that's in the middle of the screen. The dot moves to the left, and they move their eyes to the right. Back to middle, target to the right, eyes to the left, and so on. Yeah. So anti-saccades are different in that way. We require two mental processes when doing an anti-saccade measurement. So first of all, we must inhibit the triggering of the reflexive saccade. So we have to sort of say, no, I don't want to look at the bird, I want to look at the tiger. So that's the dorsolateral prefrontal cortex that's doing that. Told you my neurology is not very good, so I have to write it down. The next mental process that must occur is what's called the inversion of the visual vector, which is a very clever way of saying if the target moves that much in that direction, then your eyes will move that much in the opposite direction. Inversion, opposite, visual vector, speed, and direction, same thing, okay? So the amplitude of movement, the amount of movement will be the same as the amount of stimulus movement. And that is the posterior parietal cortex that's doing that, apparently. So we're looking here at a gross estimation of injury or dysfunction in the frontal lobe. It's the frontal lobe that's managing that cognitive process to do an anti-saccade. Funnily enough, that same friend that I mentioned earlier who works in the emergency room, he's actually he's a neurosurgeon in training at the moment, and he spent a period of time working in working with people with brain injuries, and he used to play golf with this group of patients. So he'd go to a driving range and play golf. So they'd all stand in a line and they'd hit golf balls out into a field. And he had patients with really poor inhibition control. And so remember, this is all about inhibiting a natural response. And so he said the biggest problem he had when taking all of these patients with prefrontal lobe or frontal lobe injuries, biggest problem with taking them to the driving range is that if they finished all of the balls they wanted to hit, the next thing you want is to get some more golf balls. And the nearest golf balls are those that are out on the field. So he had a lot of these patients that would hit all their golf balls, and then just go out into the field and go and get their golf balls. Everybody else is still hitting golf balls. And so he had all these patients that would go, yeah, well, I'm done. Oh, God, oh, trying to get away. And so actually what we're doing here is analyzing that kind of cognitive process, that ability to inhibit a reflexive action. I want some golf balls, I'm going to go get it. My target's moved, I want to move towards it. We're looking at a cognitive processor, and yeah, it's just, I couldn't believe it when he told me about the people just running out. They just couldn't stop themselves from going to get the golf ball. And you will have patients in anti-saccade protocols who can't stop themselves looking at the target as it occurs. So here we are looking for the opposite thing to happen. So here the target moves in one direction, and we're looking for the eyes to move in the opposite direction. Target has moved to the right, we're looking for the eyes to move to the left. Yep. So again, we have the same parameters of measurement: position, velocity, latency, phase, and directional error rate. We expect latencies to be longer in the anti-saccade protocol. And that's because we need time for that cognitive process to go, oh, yeah, it's moved in that direction. Now I need to move in this direction. So we can actually see, we can literally see how long it takes for a patient to think, which is quite nice to see. So we have some interpretation of the anti-saccade protocols. So latency issues. So if they're too slow to react, it usually indicates a frontal lobe issue, possibly with integration into the brainstem. Accuracy issues. So if they're not very precise with their eye movements, it's an issue with the integrity of the brainstem integration with the cerebellum. Velocity issues. So if their eyes are moving slowly, then we've got integrity issues with the brainstem itself. And directional errors, so they can't suppress the urge to move their eyes towards the target. Prefrontal lobe and cortex lesions that are going on there. And then phase abnormalities, so if they're speeding up and slowing down in the wrong way, you give information about the frontal basal ganglia. So we expect to see a pattern of results for certain patients. So if you've got somebody with concussion or a mild traumatic brain injury, then the anti-saccade function has been demonstrated to be reduced in mild TBIs. So failure of response inhibition can reveal impairment in the attentional control and executive function. So someone that's just had a bang on the head, they find it difficult to not look at the new target. Patients with ADHD, so adults with attention deficit disorder, they also display executive function impairment and poor inhibition control. So again, they really struggle. So you'll get lots of directional error problems with somebody with ADHD or executive function impairment. In Alzheimer's, so in Alzheimer's and neurodegenerative diseases, then anti-saccades might show a functional index of that disease progression. So as Alzheimer's and other degenerative diseases progress, then you can see an increasing difficulty in the anti-saccade protocols. And in schizophrenia as well, research has indicated significant impairments in anti-saccade task ability. So people really struggle with schizophrenia to inhibit that reflexive impact. So let's have a look at some examples. And this is a really good example because this really shows where saccadometry is better or more useful than some cases of just normal saccade testing. So this was a patient who plays ice hockey. Do we have ice hockey in Indonesia? Yeah, so it's a really, really fast sport. So the puck moves extremely quickly in ice hockey. There's also something that's quite dangerous about ice hockey, which is that there's lots of other people playing it at the same time as you. And so you bump into each other, and then when you fall over, the ice is obviously very, very hard, and you can hit your head, and it can really hurt you. However, people that play ice hockey have got a higher level of saccadic function than people that don't play ice hockey, because they have to be able to follow the puck that's moving very, very quickly and maintain their balance when they're on ice and on very thin things on ice. That's a really difficult task to do. So those people are actually very good at doing saccade testing. And in this case, this is someone who fell when playing ice hockey and had a concussion. However, when you test them with a normal saccade protocol, you can see that all of their results are actually normal. It's actually in normal latency, normal velocity, and normal accuracy when doing saccades. However, when we do sacudometry in this particular patient, they had an increased directional error rate. So especially as the time went on, by doing many presentations, they actually started to get it wrong. So they were fatiguing over time. They also had a latency error as well, which didn't occur in the random saccade. But this latency error only started to occur later on in the testing process. So this patient was very good at doing saccades, except when you make them do 100 saccades, then they started to fail. So that concussion was only demonstrable when you did a saccade protocol. Their anti-saccades also, they really struggled. So they struggled to, so you can see here, the directional error rate was really high in the anti-saccade protocol as well. So they couldn't inhibit that reflexive action. And you can see the latency here as well was really extended. The phase, again, their phase, they started to struggle to move their eyes fast enough or to slow them down fast enough when you did extra testing. You can see this latency issue that's going on there as well. You'll sometimes get this phase abnormality that occurs as well. This is a really strange phenomenon. So you'd expect phase normally, so eye position against velocity, you'd expect their, as they start moving their eyes, the eye velocity to increase, and then as they get close to the target, for it to decrease. What you get in frontal basal ganglia pathologies is that it will speed up correctly, and then it will slow down as it gets to where it should be the peak. Then it'll speed up again. So it sort of goes fast, slow, fast again. So you get this strange sort of M, or the McDonald's result that occurs. And so this is that case study then of the patient that fell. So they were tested over a period of time, over the period of a month. So they had one test 4 times over the period of a month. And you can see their latencies actually improve over time, and the directional error rate improved as well. So as that concussion improved, then we can see them improving their results. So some really good clinical uses for this test. Neurodegenerative disorders, so you can see over time the degeneration of the ability to do these things. Traumatic brain injuries, again, we can see the recovery of that, or in cases of people that are very good at sports, then we can still see the brain injuries that occurred. Neuropsychiatric conditions, so we can look at bipolar, schizophrenia, Tourette's, and ADHD. So these are kind of conditions that we might not normally think about in a vestibular clinic, but they can be indicated in sacudometry. And chronic depression as well. So these really sort of neurological conditions can be monitored. And there's obviously some really nice data that's out there as well. So I would point you at this study if you want to have a look at some of the more recent research that's going on. And this is looking at healthy versus concussed adults, and especially in the case of patients that play sport. So really important for sports medicine. And this is a big use of sacudometry in the US, using sacudometry as a way of understanding concussion, especially for patients that play contact sports like American football, where they can actually use this to assess whether a patient should go back to playing sport or not. Especially professional sportsmen, they take a bang on the head. They shouldn't go back to playing straight away, but they're professional sportsmen, so they want to. It's their livelihood. And so by doing things like sacudometry, you can safely return someone back to playing sport. So in conclusion, sacudometry helps us to really understand some of those neurological conditions that wouldn't necessarily manifest when looking at just standard saccades. And again, we can look at these different components of the eye movement in more detail with sacudometry. So there we are, that is sacudometry. A new test, a really exciting test in the world of vestibular medicine. and one where I'm expecting a lot more research to come out in the near future. So we are now moving to our next one, DVA. Yes, absolutely. How are we doing? I think I can get us back on track. So we have until 12:30. Sorry? Yes, I'm just changing it over now. Yeah. Okay. Right, so DVA to take us to 12:30. So here's what we're going to cover in the next sort of 40 minutes or so. We're going to look at the role of functional assessments, and specifically functional VOR assessments in dizzy patients. Gaze stabilization test we'll mention, but really we're going to focus on dynamic visual acuity. We won't look at postural control. We'll have a look at some case studies. I hope that we'll have time to do that. And okay, so we've looked very much at the peripheral end organs so far. And so I've really relied on your all of your understanding of the balance system to look at those things so far. But we're going to look at a functional assessment now. And so really to understand functional assessments, we should understand the balance system as a whole. And so the balance system is essentially just an organized response to some sensory inputs that have occurred. So the sensory inputs that we have in the balance system are threefold. We have the eyes, so visual inputs. We have the vestibular input from the vestibular end organs that we've looked at so far. But we also have proprioceptive inputs. So from body movements, we have inputs from our joints and from our skin that actually feels the movement that occurs. All of those inputs feed into the brain. So we have all of the inputs that occur, but for the balance system to actually work, then we need a series of motor outputs as well. So we've got all of those senses send inputs into our brain, and then our body must react to those inputs to keep us stable, to keep us standing upright. And so the main sort of motor outputs that we have are our ankles and our hips that are there to sort of keep us stable when stationary normally. Trunk and neck, that keeps us being able to keep our vision in the correct position. And then our eyes and our head, so moving eyes and head actually helps us to focus on what we're looking at, helps us sort of fixate on a particular target. Obviously, once we've got a motor output, that actually becomes our new input for our next set of balance control. So if I take a step forward, my brain is getting a response from my otolith organs, from that translational movement. As I take the step forward, I'm getting a series of inputs up my legs. And then as I step forward, I can see things are getting closer to my body. That becomes the sensory input, which means that I can actually maintain this body position. And then if I move again, that becomes my new set of inputs. It's my new output. It's my new set of inputs. So it's a constant process that's going on, our balance system, constantly reassessing all of the new inputs and creating an appropriate output. So our bodies have to do a series of things in order for all of that to work properly. So the first thing it has to do is control the eye movements to maintain clear vision. If I didn't have a good VOR, my eyes didn't move effectively, then as soon as I move, everything becomes blurry. Yeah. If you film something with your camera and move it very quickly, everything becomes blurry because phone cameras don't have a VOR. So eye movements are the first thing that needs to occur. Accurate perceptions of body movement then and body position need to come along with direction and speed of movement. So if I've moved in that direction, I need to accurately assess that. When that movement occurs, I need to rapidly change my center of gravity. If I move in this direction, but I keep my center of gravity over there, back there, I'll fall over. So I need to rapidly move my body in order to stay stable. And then I need to essentially put that center of gravity over the base of support. The base of support is essentially the width of my feet. I need my center of gravity to be in between my 2 feet. If my center of gravity is there, I fall over. Okay. So the first 2 components are it's the VOR that allows us to do those first 2 things. So controlling eye movements and accurate perceptions of body position. And then postural control occurs with these center of gravity and base of support analyses. Okay, so if one or more of these sensory inputs starts to fail, then I might find myself dizzy or unbalanced. Obviously, if that happens, then we can do lots of diagnostics and we can understand exactly what's going on. So we can do our diagnostics. Why do we need functional assessments? Well, I'm going to rely on your knowledge of hearing here. This is a very normal hearing loss that we might see as somebody gets older. How well would you expect this person to hear when they're in background noise? They might find it difficult, yeah? Could this person do well in background noise? I would say they might be able to do well. The pure tone audiogram doesn't tell us how well they're going to do in background noise. There's no way of saying just from this audiogram that someone will hear well or not hear well in background noise. And this is very obvious when you think that not everybody with a hearing loss wants to wear a hearing aid, right? Because actually lots of people they can manage quite well without a hearing aid because they're just very good at using other information to understand speech and background noise. And so this is a graph that describes that to us. So these are people with different levels of hearing loss and how well that they hear in background noise. And what you can see is that there's absolutely no pattern here, is there? We've got people, so these squares here, this square and this square is someone with the same amount of hearing loss. But this person does very well in background noise and this person does very badly in background noise. All of the crosses are people with the same amount of hearing loss, but their ability to hear in background noise is very, very different. And so by doing a functional assessment, by actually assessing how well they do in background noise, we can see the impact of their impairment. We can see the impact of their hearing loss. The same concept occurs in the balance clinic. So with diagnostic assessments, we can find out what is wrong, which organ is doing bad. With functional assessments, we can actually understand which exercises are best for rehabilitation. We can set a benchmark, so we can say, this is how well you're doing now. Now you can do some rehabilitation. We can retest you and see, are you doing better in the future? So we can track that progress over time. We can also set reasonable guidance for their exercises. So if I'm asking somebody to do VOR exercises, I need to make sure that the difficulty is the correct level for them. If I've got someone who's dizzy and I tell them, so a very common VOR exercise is just to do this, so looking at your thumb and moving your head. If I ask a very dizzy person to do that while they're standing up in the middle of a room, they're likely to fall over and hurt themselves. So I can ask them to do that when they're sitting down, and now it's safe for them to do it. However, as they improve, as they get better over time, I need to be able to increase that difficulty to effectively rehabilitate them properly. So functional assessments help us do that. And it helps us to provide solutions for dizzy patients in their real life. For example, this lady was, she actually had just an unknown balance problem, just general imbalance. And so she used the Zimmer frame to help her get around in her daily life. Obviously, that's very useful when she's walking around on a flat surface. But because she was so worried about falling over, she wouldn't go anywhere without her Zimmer frame. And that's fine in normal day-to-day life, except when she got home, because where she lived, she had these steps to get up to her home. That'd be fine for me. I can just lift up the Zimmer frame and fly up the steps. That's no problem. But she's imbalanced and older. That's actually quite difficult for her to do that. So by giving her good rehabilitation exercises, we actually just improved her confidence so that she could just use a stick. And a stick is very easy to get up and down the stairs with. So functional assessments actually help us generate these real world solutions for patients. So the very first functional assessment that we need to do is looking at that very first function of the balance system, which is controlling eye movement to maintain clear vision when the individual or the environment are in motion. So maintaining clear vision when I move my head, being able to look at something, or if that thing moves in front of me, being able to move my eyes to track that properly. I want to keep that, whatever I'm tracking, I want it to be clear and easy to see. So that is essentially the VOR, isn't it? So vestibular induced eye movement occurs. So this is the pathway that we're looking at in the VOR. The VOR does actually occur to angular stimulation and also to translational stimulation. So whether that's head moving around or moving in the horizontal planes, then our eyes are able to move to counteract that movement and maintain clear vision. So here's what it looks like in a normal patient. When the head moves quickly in one direction, the eyes quickly move in the opposite direction to accurately maintain vision. So this is essentially the clinical head impulse test, isn't it, that we're seeing here. As the head moves in one direction, we have a vestibular input from the horizontal canal. We have that VOR pathway that occurs, and the eyes move in the opposite direction. It follows Ewald's law. So a stimulation of the semicircular canal causes a movement in the same plane as that semicircular canal. So the horizontal canals generate horizontal eye movements. As long as you're non-pathological, a horizontal head movement will not generate a vertical eye movement. And please, 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 if you see a downward eye movement with a horizontal head movement, then get an MRI. And so we'd expect to see these particular movements in particular directions. Ewald's third law, excitation causes greater stimulation than inhibition. So if I move my head to the left, I'm stimulating the left canal, and that will create greater excitation, will create greater stimulation in that canal. And in the right canal, the inhibition, so the stimulation will be lower from the inhibition. So in left horizontal canal excitation, the left medial rectus and the right lateral rectus will fire. And that will move the eyes in the correct direction. So in this way, we can analyze which canals are affected. When something goes wrong, what you get is a lack of excitation, but a maintenance of the inhibition. So the brain actually will then think the left side is being excited because it's moving more than the right side. And so you get nystagmus that would occur in that direction. So that's the sort of the diagnostic components that we'd see. But what happens to visual acuity? What happens to the brain's ability to use that vision when those inhibitions, when those diseases occur? So what happens is, normal, if you move your head from side to side, normally you'll be able to read. So if you're not moving your head, you'll be able to read to a certain point on the Snellen chart. And then when you move your head, you should be able to read no worse than 2 lines above that. Okay. However, when you have an impairment of one side or both sides, what you'll find is that everything becomes blurry, or it impairs you so much that you have to move more than 2 lines on the Snellen chart. After you've compensated for that, then you should be able to read back down to that normal level again. So that's really useful to do. And you can do this in clinic with a Snellen wall chart and just moving your patient's head. However, doing that with that sort of stimulation isn't particularly accurate because there's all sorts of reasons why a patient can trick that test. And the way that they do that normally is they won't read the line, they won't read the letter until their head has stopped moving. You've told them to try and read the letters, so they won't bother reading it while the head is moving. Head stops moving. Yep, that's a W. Oh, that's an A. And so it can be difficult to understand what's going on. Also, impairments usually happen unilaterally. So if they have a right lesion like we have here, then actually when you move the head to the left, they should be able to maintain normal function. But when you move the head to the right, they will struggle to do the test. But again, a patient with a unilateral impairment will only read when you move their head to the right, and they won't bother doing it when you're moving the head to the left. And because we're having to do this at speed, you'll be doing it like that. And so you can't tell which side has been impaired when doing this. So what we have is something called dynamic visual acuity assessments using computerized protocol. So in dynamic visual acuity, the head velocity will be constant, so they're moving their head constantly, and we assess their visual acuity. So your patient will be shown these 4 different stimuli. So even if somebody doesn't know letters very well, you don't need to struggle with this. So they'll be shown one of these directions at a time, and you ask them just to say which of these they can see. So this one they say left, that one they say up, that one they say right, that one they say down. Throughout the whole test, you're moving the head at the same velocity, but the size of that optotype, the size of that stimulus will change. And so you can analyze how well they do with their head still versus in movement. So we check their static acuity and then we move their head. If they lose 2 lines or less, then it's normal. When we use a computerized system, we can make sure that we do this test extremely accurately. So what that means is the computer can decide when to show the patient the optotype. So rather than having a Snellen chart where they can always see the optotype, it's always there, the computer will only show them the stimulus when their head is moving at the correct velocity. If their head slows down, the stimulus disappears. So now we can ensure that they're only able to see what's going on when the head is actually moving at that speed. Because even someone with a vestibular impairment, if you move their head very slowly, you're not actually generating the VOR properly, then they can still see. So we make sure that they can only see it when the head is moving in the correct velocity and in the correct direction. If we're doing left testing, it will only show them what's going on with the head moving to the left. So now we can actually differentiate between function in the left and the right direction. And now it's repeatable as well. If I do this test today and I do it tomorrow and next week, then it's the same every single time. If I do that by moving the patient's head myself, I can't guarantee I'm moving at the same speed today and tomorrow and in next week as well. I have a video here which actually shows this happening properly. So I will describe what's happening as we watch it, just so that everybody can hear it properly. So we don't need to use a VNG goggle because we don't actually need to see the eyes moving. We're looking at the function of what happens, not the movement of what happens. So we can use this very sort of small headband, which I also have here. It's very light, very comfortable. And then we just put that little rectangle on the front, and that is an inertia monitor. So that's actually measuring the speed of movement. The first thing you do is a static DVA, so static visual acuity, so you're not moving the head. As you can see here, the patient is just looking at the screen, and the stimulus will occur in the middle of that black box. And it's really simple. They just have this headband that is placed on the head, and it's got a little crank at the back, so you can tighten it up so that when they move their head, it doesn't fly off the head. So nice and easy, twist that, and it's super comfortable, super easy to do. Because of course, when you're moving the head quickly, it needs to be nice and secure on the head. There's a remote control. So you can actually give the remote control to the patient, and they can indicate left, right, up, or down. Or you can ask the patient to say out loud, left, right, up, down. And then you as the clinician can press the buttons to indicate the direction that they think the optotype is in. So you start the test, and then that actually might be a little bit too small to see on this screen, but the bracket is changing direction. And the patient just indicates which way they think the bracket is going. Then we get our result. So this is a logmar. So this is the acuity of the patient. So that's essentially what your optician is looking at when you're reading the chart. Just says which line of the 10 lines on the chart, which line you could actually see it at. So we take the static acuity first, because we're going to compare that with the dynamic acuity. Dynamic acuity is when they actually move their head. So it'll be exactly the same. The brackets will change, but the bracket will only be shown when the head is moving at that correct speed. It will also only show when the head is moving in the correct direction at that speed. So you test left and right separately. So you press left first. So although they move their head left and right, it only shows the target when they're moving their head to the left. Or in this case, it's to the right. It's only showing. You can see it's only flashing up when it hits that green section, and only in that rightward direction. The patient's task is exactly the same though. They're saying left, right, up or down, and we're analyzing their best acuity. So you can see here, they've got worse by one line. So it went from 0.1 to 0.0. They got worse by just one line in the rightward direction. Now they're being tested in the leftward direction. So this time it will only show the target when they move their head to the left. And so you can independently assess whether it's the left or the rightward function that is working well or not. And it means that they can't cheat. They can't only say when they're moving the head in their non-pathological direction. So Darren here is just explaining the difference between having the patient indicate and just having the patient say, and then you as the clinician can indicate the direction. I never bother giving the patient the remote control because it can just be too confusing for them. They just say left, right, up and down, and then I just press the button. Again, you can see Amanda there is just moving ahead in the leftward direction now. She's saying out loud what she can see. And we've got the result. So what I'll do is when we get the results up on the graph, I will just describe them. Okay. So we have left and right movements on this graph and up and down movements on this graph. We can do horizontal and vertical, but we just look at the horizontal. So we have the head velocity of 0 degrees here. So that is static acuity. So minus 0.1. So that's better than 20/20 vision. Yeah. So just, which lots of people have. In fact, the woman that was being tested there is my colleague Amanda, and she had had laser eye surgery about 3 months before. So she got perfect vision now. When she was moving her head to the right, she was able to read those optotypes only one line worse. So they only needed to be slightly bigger for her to be able to see it effectively. Remember, you can lose 2 lines. You can go up by 2 of these lines, and that's still normal. It's normal to lose 2 lines in your head. However, when she moved her head in the leftward direction, you can see she's lost 5 lines, in fact, in the leftward direction. So we can actually see that it is the leftward movements that are causing her problems. And if we think back to what I said earlier, that means that when we're actually rehabilitating this patient, we can just focus on doing leftward head movements. Don't need to bother doing these rightward head movements or other kinds of exercises. We can just focus on exercising the correct direction that's impaired. And now we have a baseline of her ability. If we did V hits, we would just get abnormal V hits pretty much forever with somebody, even as they start to rehabilitate. But by doing DVA, we can actually see their improvement over time. So I'd give this person some exercises and then bring them back maybe 2 weeks later and be able to actually see that improvement occurring and improving and improving and improving over time. That's really important, I think, for modern medicine, right? If we do any intervention, we need to demonstrate that what we've done is effective and targeted. Otherwise, it's just giving out paracetamol for anyone who's got a headache. Just, and everyone can just have some paracetamol and it doesn't really make much of a difference. We want to really sort of target and focus on the impairment that's actually occurring and actually generate a program that truly sort of improves their challenges. So what you see is, as somebody gets better, their results move from being very poor to getting a little bit better over time. So before they rehabilitate, and then after they rehabilitate, the results are getting more and more accurate, more and more like normal over time. And we need to demonstrate this as people that are intervening. We need to actually make sure that what we do is effective. And then, so for these horizontal impairments that we've looked at so far, because I've just assumed you know what I'm talking about, but these are the Herdman exercises, so VOR times 1 and VOR times 2. So VOR times 1 is where you have the patient just look at something directly in front, move their head, and just keep their eyes targeted. And then VOR times 2 is where you ask them to move their head and target at the same time. And what we do is steadily increase the difficulty of doing that. So always to start with, have the patient sitting down and have a blank wall in front of them. So there's not very many other sort of visual distractions getting in the way. And then I would say, add maybe some complexity. They still go? Yeah. So VOR times 1, so sitting down and steadily increase the visual background, and then have the patient stand up and do those exercises. But I would say when you first have them stand up, have them stand in the corner of the room so that if they do fall, they're protected. And then you could have them, say, doing that and standing with their feet one in front of the other. So it's more difficult now to maintain postural control, but we're improving the task. And then you can even have them walking while doing this in the future. but steadily increasing that difficulty as we go. And then the VOR times 2. So this is essentially doing exactly the same thing, but changing the velocity and the angle that they have to do this at. So really moving that field of vision in a much wider arc rather than just like this. We can get them to do it in a much wider arc, but steadily increasing. We need patients to do about at least 15 minutes of exercises a day, and in blocks of 15 minutes. So just doing this for 20 seconds and doing that once an hour all day isn't good enough. We need to actually really sort of challenge the system. Same way as when you're exercising. Doing this and then having a rest isn't very much exercise, but going for a run for 10 minutes, that's plenty of exercise. So at least 15 minutes and a block of 15 minutes of exercise every single day. That's what the American Society of Physiotherapists, or physiotherapists will recommend. However, you will absolutely have patients who can't sustain that much exercise for that much time. So really sort of tailoring and working with your patients as individuals is extremely important to make sure that they're actually rehabilitating properly and effectively. Okay. Brilliant. I'm on time. I'm back on track. In fact, I'm now ahead of time ever so slightly. So that's nice, isn't it? So we are into the portion of Q&A, and we've had loads and loads of sessions this morning of all sorts of different topics and things. So I'm sure we've generated plenty of questions. We'll see what we've got. Yes. Okay. So the question for those that didn't hear and for those online, minimum age for VHIT and VEMP testing, and what differences should we expect with technique and results for pediatrics? Yeah. So VEMPs, you can do VEMPs on pretty much a newborn. Yeah, you can. So if you can, in some, maybe a little bit older, 3 weeks or so, lie them on their back, have something in front of them that is interesting, and really sort of move their head and their eyes, you can actually still generate those responses. There's no normative data. So you won't be able to say, this is the correct amplitude and this is the correct latency, but you can assess left and right separately. VHIT, a bit more difficult in terms of age, because it really depends on the child that you've got in front of you. But I would say with head impulse, just head impulse testing, clinical head impulse testing, you can do that with someone of a very young age, maybe a year old. If you can get a sticker of a smiley face and put it on your nose, or their favorite animal or whatever, and you can do that, and you can get them to do that very well. VHIT testing, you need someone who's a little bit more compliant, but you can get goggles onto a small patient quite easily. So these are VHIT goggles, and they're designed to be really lightweight and super flexible. So they will go on a tiny little head quite easily. They can be, you need them to be tight, so it can be uncomfortable. So you have to find a good way of distracting the children while doing this kind of thing. Pediatric vestibular testing is a whole world of its own, and we do have some resources on the Interacoustics Academy website. We've had, over the last 2 years, 2 separate lectures on pediatric vestibular audiology that I would recommend you go and see. And there's some colleagues who are really experienced in doing that. So someone like Violette Lavender, who works in the US. She has a clinic where she works with pediatrics a huge amount. She has all sorts of really good techniques for all of this kind of testing. I'd say with young children, especially like babies, then looking at reflexive function is probably your most important thing. So looking at the spinal reflex and cervical reflexes. So literally some really simple things like holding a baby and tipping them forward. You should see their head do that and their backs do that. So you can actually see that, and that is a vestibular reflex that's occurring. So it's a vestibular spinal reflex. In terms of technique for things like VEMPs, what's really nice about children is they love looking at screens and cartoons and things. So if you've got a TV screen, just put their favorite program on there. And if you've got a chair, so if that's our TV screen, I can sit them like this, sit them on mum's lap, and they're going to look at that. They're going to look at the screen, and now I can do a VEMP really easily. Or maybe they're a bit distracted by everything that's going on in the room. Bubbles. Bubbles are the best thing for a pediatric clinic all the time. Just have someone standing there behind them, and every now and then blow bubbles, and that kid will just always come back to looking over that side. So yeah, all sorts of different techniques, but really there's research now going on in newborn vestibular screening. So doing VEMPs on newborns and all sorts. So yeah, there's a lot to come. But you had some more questions, I think. Yep, absolutely. So if a patient's wearing glasses for DVA, if the patient normally wears glasses, yeah, they can wear glasses when doing DVA. That's why we have a headband like this. For VHIT, they won't be able to wear their glasses because the goggles need to go over the top. Yeah, so that's the really tricky thing then, is if they've got very poor vision, then being able to see the dot is difficult. So you need to have something of very high contrast. And maybe the more obvious thing to say is to put the patient closer to the target so they can see it. But if you do that, then their eyes will converge, and that reduces the saccades that can occur, and it can reduce the ability to do a VHIT test. So don't put the patient closer, have a high contrast target for them to see. Yeah, so what's the ideal is to have a yellow background with a black dot. Yellow background, black dot. Yep. You can make the dot a bit bigger, but if it's too big, then they'll be able to see, you know, as you move the head, they'll be looking at this side of the dot and then this side. And so really it needs to be small, but high contrast if they've got visual impairments. Contact lenses should be fine, but just be cautious about the how far you're doing the impulse, because if you go very far, then actually they might be looking out the side of the contact lens. But that's good technique for VHIT anyway, is only to do very small head movement. Less than 10 degrees of head movement is fine for VHIT. And your third question? Is it in one eye only? In both eyes, yeah, okay. So if you've got only one eye that's impaired, just put an eye patch on and do the assessments. Yeah, if they have big problems with eye movement, just normal oculomotor function, then you will struggle to do VHIT. It relies on normal function of the muscles. And then also if they've recently had eye surgery, not doing any vestibular testing is important, because normally in vestibular testing, we induce nystagmus of all sorts of different types. They've just had eye surgery, they're at risk of bleeds, and we don't want to do that. So yeah, really difficult with those sorts of patients to, we rely on the eyes to test the vestibular system. And if they've got big problems with both eyes, then yeah, you're gonna find that difficult, I'm afraid. Sorry. Thank you. Do we have any other questions in the room or online at all? Yes. Hello.
Check every account with linear and also function as well. So how about this experience? We will contain we will have kalori, so and we find that utilization as a normal gram, normal digit, and also on the different website test, the positional test is the normal. And we think that we just is
Yes. Yep, absolutely. So if you can test the all of the end organs independently and they're performing well, then yeah, what you can say is normal peripheral function, query central function. So really you need then to refer to someone that has VNG or maybe the ability to do MRI or other kind of scanning. It's very common that vestibular clinicians are working without VNG. That happens quite a lot around the world. And in fact, some vestibular clinicians will say, I don't need VNG because I can just do an MRI. And in some cases that is the case, but there are also many central vestibular lesions that are frankly too small to be seen by normal MRI. Yeah, so you need like 3 Tesla MRIs in order to see lots of vestibular central lesions that you would normally see on VNG. So it's really tricky, but yeah, my favorite stuff to do is all of the vestibular end organ testing. And so there are many clinics that do, they just call themselves peripheral vestibular clinic. And so they'll just do that end organ testing and refer to a neurologist for the central condition. Yeah, and that's a really good way of setting up work in a hospital as an ENT or an audiologist, is to do the peripheral things and then send anything that's central to the neurologist.
Any other questions on the floor? Okay, if not, I saw the 2 questions online. The second question, I think, is related to we just discussed. The question is how to set your balance in children if the children are balance examination.
Yeah.
It's related with you already.
Well, actually, that's reminded me. So don't be scared of children in vestibular clinics. There's a lot that we can do, even if it's your non-traditional kind of things. So and actually, some of this relates to adults as well. Some of the best things you can do in vestibular clinics is just analyzing the patient as they move around the world. If you're, there's lots of hospitals where you have a waiting room and then you've got your consulting room and somebody else will bring your patient to your consulting room. Normally that's fine. But if you're doing vestibular medicine, go and get your patient yourself. Always, always, always go to the waiting room and watch your patient. Call their name, see how they stand up, see what they're doing, how they walk towards you. Ideal if you can have at least 1 or 2 corners between you and your waiting room. Then you can see how they navigate a corner like this. Even having, like a trolley or something, a chair in the corridor, see how they walk around the chair or if they're touching it to walk around. Those walking straight down a corridor, see if they're veering to one side, see if they're putting their hands out, all of these things. And then relating that to pediatrics, play some games in your clinic room. Have a teddy bear over here and a teddy bear over there and say, ooh, go and get this one, and then go and get that one and see how they get over to it. Have things at different heights. what's really interesting is some patients, especially pediatrics with vestibular conditions, they might be fine sort of in this plane, but in the vertical planes, things can really change. So they need to reach towards the teddy bear that's up there and they go like this, or they want to get something off the floor. Most children are able to sort of slowly bring themselves to the floor, but children with vestibular impairments will do things like, and then go and get their toy. So, can they actually bend down and do these kind of things? So there's lots you can do that's sort of non-traditional, but you can really sort of analyze their function. So yeah.
Yeah, that's why something different. The question is whether the frame result will be affected by a central lesion.
So it depends where central lesion is and at what point we think it is. So if I return on here, so primarily we're looking at peripheral conditions, but there could be a lesion anywhere along this pathway, right? And so if you have a lesion at any point on this pathway, so vestibular nucleus, for example, then that is likely to impair the VEMP response. So how can we see this? Well, luckily, we can look at the responses from either ears and see if there's one long latency from one side, especially if it sort of occurs on the vestibular nerve or early on. So before it crosses over, then we can actually see those central conditions occurring there. So that is the use of VEMPs being left and right, is you can actually analyze the pathways kind of separately and where they cross over. It's not very common though that you would only see a central condition affecting the VEMP. You'd normally see it affecting other components of the vestibular system as well, or other sort of very strong central indications first. So I wouldn't rely on the VEMP to indicate central pathology, because it can only really show you anything on this pathway. Anything else, then it will miss. So we definitely need the VNG and those sorts of things to look at central conditions. Yep. Fantastic. Thank you.
Bapak Ibu, sekarang waktunya untuk kita akan tanya. Yang Assalamualaikum warahmatullahi wabarakatuh. Ya. Bapak dan Ibu dokter serta rekan-rekan insan Kasum, kita akan melanjutkan materi sesi yang kedua ini ya untuk hari ini. Untuk sesi pertamanya nanti masih ada materi dari Jack Bennet, nanti akan masih dipandu sama Dr. Siti Faiza, berikutnya akan ada praktek ya Bapak Ibu ya. Oke, kepada Dr. Siti Faiza kami persilakan.
Yeah. Okay. Thank you. So next will be the last topic, yeah. It's about VHIT and then followed by hands-on demo and hands-on. So give time to you to start.
Okay, thank you very much. We have the projector on. So just get that to switch on.
Untuk sejawat yang online, kalau masih ada yang pertanyaan menyusul dari topik yang sudah dikemukakan di sesi pertama, silahkan tinggal ditulis di chat. Akan ada hadiah loh.
Give me just a second. Okay, so that should now be, sharing the screen. So we've covered a lot already today, and we've now just had a very tasty lunch. So hopefully I'm going to keep you excited enough to stay awake for the rest of the afternoon. But what we'll do is look at, in quite a lot of detail, the head impulse test. I've mentioned it quite a few times throughout the day, but we've not really looked at how you actually do head impulse testing. So we'll do the presentation first, where we'll go through absolutely everything you need to know, and then we'll do some practice, because there is nothing better than actually practicing a test like this. As we were discussing this morning, technique and practice with VHIT testing is essential. So we'll go through how to do all of that. And I've brought a system, but I think there's also a system here, so we might even be able to have two sets going at once. So we should all have plenty of time to do the test, to have the test done on us, because I think that's also very, very helpful. For those that are online, obviously the hands-on session won't be very helpful, because they, unless they've got extremely long arms, they won't be able to do the hands-on. But that's why we're also going to do a lot of detail now, just so that everybody can benefit from it all. So as you know, the vestibular head impulse, the video head impulse test is a vestibular test of the function of semicircular canal. We can do similar things to the video head impulse test by doing the head shake test, for example. But the head shake test has lots of limitations versus the video head impulse. But we're actually going to go right back to the start and go and have a look at how we do head impulse testing without technology, first of all, because many of us that see vestibular patients can do head impulse testing just very, very quickly at the bedside and get a lot of information from that. So as we saw earlier, the VHIT is a test of, or rather HIT is a test of the VOR. And so what we normally expect to see is there's the head turns, the eye turns in the equal and opposite direction. So this means as someone's looking at you, they can always keep their eyes facing towards you. So that's what it looks like in someone with normal vestibular function. But what does it look like if you have a peripheral loss? So this comes from a colleague in Portugal. You can see here, as a head impulse happens in that direction, that's fine. and then in this direction, very, very different. So absolutely fine, we're moving that way, and then this very delayed return of the eyes well after the head impulse has happened. So what that tells you is when the head moves in one direction, then that automatic reaction occurs. When it moves in the other direction, when it's moving left there, the patient has to wait until their head has stopped moving, and then the eyes can flick back. When the eye flicks back, that's what we call a saccade or a saccade. So we're looking for this when we're doing head impulse testing. Doing it like that, that's very obvious. You can really see something that's gone wrong with the patient there. However, there are saccades that actually happen during the head impulse as well. And so you can't see those saccades with the naked eye. So that's tricky to see. Something that we always need to sort of bring up and mention is that turning the head does activate both canals. We did mention earlier about Ewald's law, where excitation creates a bigger response than inhibition. So we'll have a look at what that actually means now. So a patient looking at the dot in the center there, we can see the function of the left and the right semicircular canals now. When you're not moving your head, then the semicircular canals are firing, they are sending a neural signal, but it's a low-level neural signal. When the patient moves their head in one direction, then you get an increased firing from one side and a decreased firing from the other side. So you have that inhibition that occurs. And you can see there, especially with a fast head movement, actually completely inhibit the response from the opposite side. So that's really important. So that slow moving, you see a slight reduction on one side and a slight increase on the other side, but a very fast movement, then you see complete reduction of response from one side and a huge amount of response from the other side. So in normal VOR, then the eye will move at the same time as the head. In pathological VOR, so in this case, the left ear being pathological, the eye will move with the head and then flip back. Okay, and that's what we saw. That's what we saw from that patient earlier. This next video is from someone who also has a VOR impairment, but the saccade occurs during the head movement. So with these head movements, this is actually a pathological VOR in this case, but we can't see that with the naked eye. It's happening way too quickly for us to see that pathological VOR occurring. So how can we actually see the VOR impairment? So the direct observation, as we've already done, there is something called the scleral search coil, which is where you put essentially an electrode on the eyeball itself. Okay, and in this way, then you can measure the movement of the eye. So that's like that's a coil of wire, and then you have a magnetic field around the patient's head, and then as you move the patient's head, the movement of that coil in the electromagnetic field then generates a electrical impulse. That, however, is really difficult to do in clinic. It's very uncomfortable. And you need a lot of equipment, and you need to be in a Faraday cage first of all, and then produce an electromagnetic field. Very difficult to do. So the video head impulse was created in order to measure the VOR much more easily and much more simply. So we have the V-hit goggle. And actually, I will, Danny, if I that you can just pass that around so that as we describe it, everybody can have a good look at it. So the goggle is a very lightweight goggle that goes on the head. It has just pass it around and yeah, people can see. It has an infrared camera on it. And it also has what's called an inertial measurement unit. So that will measure the movement as well. That camera can be placed on either eye. So you can remove the camera and put it onto either eye. The little glass frames that are in there, they're reflecting back upwards. So obviously if we put a camera right in front of the eye, then the patient will be looking at the camera and not at the target that we need them to look at. So having the camera facing towards the glass means that the reflection of the eye in the glass and the camera can then see that. So the camera is responsible for measuring the eye movement, and the inertial measurement unit is responsible for measuring the head movement. So we're measuring two things at the same time. We measure the head moving and we measure the eye moving. And so we generate a graph that looks something like this. So the top of the graph, this here measures the head movement in degrees per second. And then this part of the graph measures the eye movement in degrees per second. And then in this axis, we're looking at time. So what we see is something that looks like this. So as the patient moves their head in one direction, then their eye will move in the opposite direction. So the patient has moved their head to the left, so we can see that movement of the head to the left. So it speeds up and then it slows down. And then the eye will move the same amount, but in the opposite direction. So the eye has moved, it's speeding up, peak velocity, and then slowing down again. So over the case of 350 milliseconds or so, then we can measure the head movement and the eye movement. So we expect that to happen. Head moves in one direction, eye moves in the other direction. That's the VOR. However, if somebody has a peripheral loss, so if that left ear, for example, is not working properly, then you'll see something like this. The head moves and then the eye moves. And then that looks like this on the graph. So the head has moved, it's sped up and slowed down, just like it did before. But what happens now with the impairment is actually the eye doesn't really move when the head moves. It doesn't move at the same rate. And then when the head has stopped moving, then the eye will quickly move. Okay, and that's that quick saccade as it returns to the target. So that's happening now after 200 milliseconds. So the head has stopped moving, and then the eye very quickly moves to catch up. And what we can see is that unequal eye movement in respect to the head movement. And then we see a catch-up is made to correct for that. So this type of saccade that we see when the saccade occurs after the head movement, that's called an overt saccade. Overt just means it's very obvious, you can see it. And that's where we see this peak response, this very fast response happening after the head movement. What you also sometimes get, as we saw in the videos, is head and eye movement happening at the same time, but unequally. So this time, the eye is moved unequally to the head, but it has moved at the same time. And we can see a catch-up saccade is made to correct for that head movement. But this time it's happening covertly, so it's happening during the head movement. So that's what happened when this chap here, JC, when he had his head moving, the eye didn't really move very much, and then it quickly caught up, but well after the peak of the response. And then by the time the head came to rest, the eye had already moved in relation to that. So again, these covert saccades, you won't be able to see those just using the naked eye. They happen way too quickly. So there's a sort of a 5-step process that we use for measuring the VHIT in patients. First of all, the very first step is patient setup. Very important to set a patient up correctly when doing VHIT testing. Also, we need to calibrate the system for that particular patient so that we can make sure that the movements were correct. Thank you very much. And we can make sure that the measurement that we've made is correct for that patient. Obviously, we all have different head shapes, different face shapes. A movement of 5 degrees on my head is actually different to a movement of 5 degrees on your head. That inertial measurement unit will move a different amount. So we need to calibrate the system for each patient individually. The third thing to do is to measure lateral impulses. So that's with the horizontal canal. And then measure LARP responses. So LARP, left anterior, right posterior. and then route responses, right anterior, left posterior. Okay. So we take and we face them towards the wall. And there's a nice indication here of where the semicircular canals are actually pointing. You can see the horizontal here, the anterior and posterior here, for the left and for the right. We need to place the patient at least 1.5 meters away from the target. And that's because if we get any closer, then the eyes will converge. They have to point inwards in order to keep their eye on the target. And we don't want that to happen. That can affect the head impulse. So that can affect the eye movement. And that is a challenge when doing clinical head impulse testing, because you need the patient to look at your nose, but my arms are not 1.5 meters long. So we do have convergence when doing clinical head impulse testing. We want to make sure the patient's not sitting on a chair that can turn. They need to be on a fixed chair. Obviously, if I'm moving them, then we can end up moving the whole body and moving the whole chair, which we don't want because that's not very safe. We need to make sure the target is at eye level to the patient. Okay, we don't want them looking up or looking down because we're going to be moving the head in this direction. So just from the sort of the environment setup, you need to be quite clear and quite accurate with the way that you set it up. But that being said, it's very easy to take VHIT equipment to different rooms, different clinics, because all you need is a sticker to put on the wall and a blank wall. Even something like this is very useful. You can just draw a target on there, and then you can move that, around anywhere in the hospital or anywhere in the clinic. And the equipment is very light and easy to move around, so you can take it anywhere. Okay, so we need to make sure that the goggle is very tight on the patient's head. We want to essentially connect the head and the goggle together, because when we are measuring the head movement, it's actually measuring the camera movement. It's measuring the movement of the goggle itself. So if we've got a goggle that's very loose on the patient's head, as I move the head, then the goggle sort of slips around a little bit, and we don't want the goggle to slip when we have it on the patient's head. So we have this adjustable strap that's on the goggles. So making sure it's nicely and securely on the patient's head, and then pulling that strap tight, because we need to make sure that it's really sort of holding the goggle on the patient's head, making sure it's really nice and tight. And then we need to calibrate the system as well. We need to calibrate both the camera and the inertial the inertial measurement as well. So calibration is really very easy to do. There's a little laser pointer that's on the system, and it will actually project. You can see just the little red light on there, and it will project some dots onto the wall. And you ask your patient to keep their head still and just move their eyes to the different targets, the different dots that are on the wall, and then back to the center dot as well. So eye calibration makes sure the system can accurately identify the eye movement, because again, a little bit of eye movement in my face is different to that amount of eye movement on your face as well. And then we need to do head calibration. So again, you just have the patient look straight ahead, but this time we're just going to move the head left and right, and that's just teaching the measurement unit how much movement is occurring, and then you do that vertically as well. If you move the camera when it's on their head, you twist it around or adjust the goggles. If you adjust it a lot, then you need to repeat the head calibration. If that camera is here versus here, then that head movement will correlate to a different amount of camera movement. And so you need to make sure that it's, if you move the camera, so if you switch it from the right eye to the left eye, for example, you need to make sure you've recalibrated. Done that one. Okay, And then we can actually, once we've done all of that, we've set the patient up, we've got them all ready, then we can do some impulses. So impulses should be rapid and unpredictable in both direction and time. So what I mean by that is, I don't want my patient to be able to tell when I'm going to move their head. Because if they know when I'm going to move their head, then they can move their eyes to sort of compensate for the lack of their VOR. So if you do head impulses, 1, 2, 3, 4, 5, 6, the patient will just move their eyes. 1, 2, 3, 4, 5, 6. They can tell. So really, you want to do head impulses like 1, 2, 3, 4, 5, 6, 7, 8, something like that. You've got to trick your patients. You also don't want them moving their head for you as well, because you sort of lose control then. So you need to be sort of firmly in control. We don't need to move the head really far. And so always, absolutely guaranteed, the first mistake that people make is they try and move the head really far when they're doing a head impulse test. It's very difficult to move a head quickly and far at the same time. But also, we don't need the head to move all the way over here and all the way over there. 10 to 15 degrees is all we need to do. And that's really beneficial, especially if you've got some older patients who maybe have got a sore neck or a stiff neck, then that's okay, because as long as they can move their head this much, then we can do head impulse testing. They don't need to move their head all the way to their shoulders or anything like that. We do need to move the head quickly, though. So we need the peak head velocity to be 120 to 150 degrees per second minimum. Okay, we really need to generate that. The reason for that is we need to try and, remember, we need to really inhibit the response from one side. So you have to saturate, you have to move it as quickly as possible. 120 degrees per second is sort of your minimum. You should aim for 150 degrees per second, but anything up to even 300 degrees per second is fine. And the system will tell you how fast you're moving the head, so you know whether you need to move it faster or slower. We also need to get some data that's repeatable and repeated. So doing just one head impulse in each direction is not enough. We need to do multiple impulses. And again, we were talking this morning, we've got a lot of talking done this morning. Talking about how many should you do, and always I'll recommend about 20 when you're new to doing video head impulse testing. And that's because we want to make sure that we can remove any of the bad impulses. So you should at least test about 20, but you can then delete maybe 5 or even 10 of those. What we need to aim for is at least 5 to 10 good impulses in each direction in order to get good, accurate results. And that's accurate in terms of the measurements that are made, but also when we're analyzing the traces, we want some repeatability in those traces as well. So we rapidly move the head in the left and the right directions, and we need to get it going in both directions. And when you've moved the head at the correct speed, then the system will tell you. It'll give you a green tick and a nice ding sound, which is very satisfying. If you don't move the head fast enough, you get a big red X and a horrible sound that's not very nice, so you want to avoid that. Okay, so technique-wise, there are different techniques for doing this, and we'll go through them all. So some people will hold the jaw, and you can just see here, very small little movement like that. You can also hold the side of the head here. Notice, however, that the clinician isn't touching the goggle and isn't touching the wire on the goggle as well. You want to avoid that. If you're touching the goggle or the wire, then you'll end up pulling it and slipping the goggle. So that's why many people will actually recommend holding the jaw as the best technique, because you will avoid the goggle. But some people find it easier to hold the head here. People with long hair, people wearing headscarves and these kind of things, if you put your hands up here, then you're just going to be slipping the headscarf and slipping the goggle on the long hair. So not very useful. So hands on the chin. Since masks have come in, then again, it's become a little bit more awkward to do that. So, you know, your patient is facing away from you. I'd recommend just removing the mask for the few minutes while you're doing the head impulsing, just so that you can have good control over their head. And then when you've done some good impulses, this is the information that you'll get on the screen. So we have the eye movement. Sorry, the head movement is the blue and the red lines. So in the leftward and right direction. So when impulsing to the left, it's a blue line. When impulsing to the right, it's a red line. And then you have the eye movements, which are in gray, okay? And you can see they go in the opposite direction to the head movements. Then we also have all of these numbers down here. And so what this system is actually doing is measuring the difference between the head velocity and the eye velocity at particular times. Now, it is actually measuring it at 40 milliseconds, 60, and 80 milliseconds, and then also an average from 0 to 100 milliseconds. But the most important one of those measurements is at 60 milliseconds, because at 60 milliseconds, that's when you get to the peak head velocity. That's the really key thing. We want to look at what's going on at peak velocity, so at the very top of the movement there. And so it's measuring the difference between velocity at these two times, and it's taking an average of that, and you generate the result from that. So the 60 millisecond is the most important one. Then we also have the graph down here, which looks at gain. So again, the difference between the two. Gain at different velocities. So when the head was moving at 150 milliseconds, then you get the gains here. But we also want to test at higher frequencies than that. So there's up to sort of 200 milliseconds here. You can go right up to, degrees per second, go right up to 300 degrees per second. And a bit like doing an audiogram, it's good to get multiple frequencies, low frequencies and high frequencies. There's evidence that some conditions will only show pathology at high frequencies and some only at low frequencies. And then we also have regression analysis. So here we have a plotting of head velocity and eye velocity at the same time. So when so it plots a line of best fit. So what it does is it takes each of these points at 0 degrees per second, 10, 20, 30, 40, 50, 60, all the way up to 100 degrees per second. So it matches then the eye velocity and the head velocity. So you get an average of the gain across the entire head impulse, not just at those particular points as well. So that sometimes it's a bit difficult to understand that one. So at 100 degrees per second of head velocity and 100 degrees per second of eye velocity, so here and here, then you have the gain between the two. So that's plotted here. And then also at 100 degrees per second here and here, there and that. And then at 50 degrees per second here and here, that would be plotted there and there. So you get all of these little plots, lots and lots and lots of them. And then you put a line of best fit through all of them. And that gives you your gain for that whole direction, and then the gain for the other direction. And here you can analyze the difference between leftward and rightward, so you can get a gain asymmetry result. What you can also do is see how consistent your head impulses were in terms of velocity across the entire set of testing. So it's a good way of analyzing how good your technique was for that particular test. When we do some hands-on, that will be a little bit more clear, I think. So obviously then we should have some normal results. So at 60 milliseconds, then the normative value should be no less than 0.79. So 79% gain, essentially. The asymmetry between the two of the left and rightward impulses should be less than 8%. So the asymmetry less than 8%. If it's more than 8%, then it's asymmetrical. That's useful if you've got reduced function on both sides. You can see which one is worse than the other even. Or if you've got borderline function on both sides, but you think there's something wrong with one side and not with the other, then the asymmetry helps you see that as well. So this is what an abnormal result looks like. So here we can see the gain at 60 milliseconds is 0.21, so well below that 0.79 result. You can see the gains across all of the frequencies of head movement are very low as well, so well below that result that we want. And then here we can see loads of essentially squiggly lines, right? But what we're actually seeing are all of the saccades that have come in. So you've actually got a mixture of overt and covert saccades for this patient. We can also see that the head movement was very fast, but the eye movement in relation to that is much smaller. Yeah, that peak is much smaller than that peak. And then these are all the catch-up saccades to recover for that. The patient's eye is not moving lots and lots and lots with each head impulse. This is just all of the catch-up saccades happening, just sort of all overlaid on top of each other. So you can see here, there's absolutely loads of saccades, loads and loads of saccades. Some of you that are eagle-eyed might have spotted this here, which looks like a saccade, yeah? But not all saccades that we measure are pathological. So there's a way that we can analyze each saccade to see if we think it's pathological or not. So the first thing we should say is a saccade that is truly pathological, the actual saccade itself should be 100 degrees per second or more. So it's a very fast eye movement that occurs. And there should be a difference between both sides of at least 40 degrees per second. The second thing that we should say is that saccades should be repeatable. And they should occur in at least 50% of the impulses that you've done. So if we go back to that last one, there's only one saccade here, right? That's not pathological when we've done 20, 30, 40 impulses on this side. 13, sorry. So we've done 13 impulses and only one saccade. That's not a pathological saccade. And it's happened well after the head impulse as well, like really, really long afterwards. That is probably just the patient looking around. They've just moved their eyes after the head impulse has occurred. So we should see them being at least 100 degrees per second. And they should be happening at least 50% of the time. There are some very sort of avoidable mistakes that occur, some common sort of, mistakes that happen. So you can see here, there's a difference in time between the head impulse in red and the eye movement in black. See, they're sort of separated from each other. And that's because the strap was loose. So the goggle was slipping around. Here you can see the eye was moving much faster than the head. Eyes cannot move faster than the head when it's the VOR that's occurring. So here the calibration was actually incorrect. We have these little saccades that are occurring here. They're actually eyes blinking. Okay. So very small little blinks. And then this is the eye blinking very heavily. So we have this little peak and then another peak. This is another blink occurring. This happens quite often, again, in new testing. You see an impulse in that direction, and then like a little impulse in the other direction at the bottom. This is when the clinician has moved the head twice. So rather than just impulsing in one direction, they've gone. And that's really common to see from a technique point of view. People are always doing this. You want to just impulse in one direction at a time and not sort of bounce backwards. Here, the eye doesn't seem to be doing anything that the head is doing. It's sort of all over the place. And that's the patient's just eye moving around. So they're not paying attention very much. So they're not focusing on the dot throughout. And then this sort of very sharp, peaky, 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 peaky. That means the pupil is not being tracked anymore. So the system has failed to track the pupil. That can happen if the camera's not aligned properly. So sometimes the pupil will actually move out of the view of the camera. But it can also happen if the patient's wearing lots of eye makeup. So this happens quite a lot. If patients come in with very heavy mascara or lots of eyeliner, then the computer will get confused and it will think the black mascara, for example, is the pupil. And so it will sort of track the wrong thing. So we've done horizontal impulses, so now we can look at the vertical impulses. So now we're going to look at the left anterior and right posterior impulses. So the left anterior here and the right posterior here. So if we impulse the head in this direction, this sort of diagonal direction, as we move it forward, then we're looking at the left anterior, and as we move it backward, we're looking at the right posterior. So if your head is moving in that direction, left anterior, right posterior. And then in the other direction, we have the right anterior here and the left posterior here. They line up perfectly. So you do a right anterior and left posterior. Again, small movements, 10 to 15 degrees. You don't need to do, don't need to yank the patient's head off. Peak velocity, again, 150 degrees per second is what we're aiming for. And they should be unpredictable. Again, we don't want the patient moving their head or their eyes on their own. So fast and unpredictable, but small. They don't need to be big impulses. So it looks like this when I'm doing it. The patient is looking at the dot. Doing a LARP, so left anterior, right posterior. So they're looking straight ahead, right posterior in that direction. So they're looking ahead, straight at the dot, and just moving their eyes like this, moving their head like that. Other manufacturers of video head impulse equipment will recommend turning the head to one side and impulsing like this. The reason for that is it's perfectly valid, and you can do that with this system. But the reason other systems they recommend doing that is because they use a different measurement technique, which is called area under the graph. So they measure the area that's underneath the graph. And what happens there is that if you have torsional eye movements, which you do have when doing this, then it can throw out the calculation. So they need to remove the torsional component by turning their head to the side. And so you'll see some people will say, yeah, have a dot at the front and then a dot to the right and to the left. And you have to point the patient's head at the other dot, but keep their eyes on this dot. You don't need to do that with this system. You just have one dot straight ahead and just impulse and move the head in the correct plane of motion. When you've done a test of each of the canals, so you've done your laterals, you've done your routes and your LARPs, then you get this very handy graph which plots the information of all of those different tests onto one graph. And it's even oriented, so it's designed so that it matches the anatomy of the patient. So you've got your right as you look at your patient. So right lateral, left lateral, right posterior, left anterior, right anterior, left posterior. So it's arranged just like the anatomy is arranged. So you can see all of the traces. You can read the values as well, so the actual gain values from each of them. So this is really useful, especially if you've got somebody else doing the testing for you and then you're just reading the results. Then just on one page, you can have all the results you need. So that's really nice and simple. And then my favorite table, as we've seen before, by doing all of those canals, then you can really get an individual analysis of each canal in each direction. Put that together with the other information from VEMP, and then you've got all of your semicircular canals and all of your vestibular end organs measured. absolutely loads of clinical applications for VHIT. The first is diagnosing the deficits of each of the canals, as we've discussed. So you can do all of the 6 canals individually. So that's a really helpful reason for having VHIT. The second is differentiating between stroke and peripheral vestibular loss. So doing the HINTS protocol is really, really helpful, especially in the emergency room or somebody with an acute vestibular problem or acute dizziness. Really, we want to rule out or rule in stroke as quickly as possible. Because obviously, if someone's having a stroke, then we need to treat the stroke and not sort of treat it as a vestibular loss. So in this case, we do a head impulse test, and somebody who's got a vestibular loss will have a positive result in the head impulse test. So they'll have an abnormal result. If you're having a stroke, with dizziness, you'll have a normal head impulse test. Test of nystagmus. So vestibular loss, you will have spontaneous horizontal nystagmus. If it's a central problem or a stroke, then you might have vertical nystagmus. And I told you earlier, didn't I? If you get vertical nystagmus, then you need to be careful. Or they might have direction changing nystagmus. So it might be horizontal, going left, 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 and then suddenly it changes and it starts going to the right. Then that's a potential stroke as well. And then the final component is the test of skew deviation. So this is where you're looking for the eyes to be unmatched in terms of their vertical alignment. So you sometimes get people that have a slight head tilt if they've got a peripheral vestibular loss. And that's because they're realigning from their eyes being skewed. And the way that you test this is that you ask the patient to look at something behind you, roughly 1.5 meters away, cover up one eye, and then cover the other eye. And you'll see if they do have skew deviation, you'll see the eye as you uncover it, sort of, if you cover up the good eye and the eye that's skewed, then the eye will move. And so you see the sort of difference in orientation of the two eyes. So having a head impulse, a video head impulse equipment is super important in the HINTS protocol. Because as we said earlier, there are some peripheral vestibular losses that you can't see the saccade happening during the head impulse test. So you might think someone's having a stroke when they're not, if you do VHIT, or if you just do a clinical HIT test. We can monitor the recovery. I told you that. So we can monitor the recovery of compensation in patients if we do VHIT testing. So these results here are an example of a child that had a vestibular rehabilitation. And there you can see the saccades here were very prominent and strong before rehabilitation. And then after rehabilitation, you can see they've improved. So the saccades have actually disappeared from the right-hand side, and they've vastly reduced on the left-hand side. So as the brain has learned to work with that vestibular impairment, then you can see the improvement of it on VHIT. And that's really important because we want to prove that things are improving properly. The caloric is our gold standard test for horizontal canals. But there are many patients who it's not possible to test calorics with. For example, if they have growths in the outer ear, if they've got infections, they've got something wrong with their middle ear, then the heat transfer won't occur. So being able to test when their ear canals don't make it possible is really important. And then combining VHIT with, oh, here we go, got another. So caloric testing isn't possible on many children because they will just close their eyes, but you can do VHIT testing with children's ear. Here you go, you can see probably about a 3-year-old child there that you can do VHIT testing with. Then you can also combine your caloric results and your VHIT results to differentiate different diagnoses. So here we have an example of Meniere's disease, where we expect to see normal V-hit, but pathological calorics. So although they're testing the same organ, the V-hit being a fast frequency response, then Meniere's disease isn't impaired in the high frequencies, but it is impaired in the low frequencies, which caloric testing does. So if you've got normal caloric and abnormal V-hit, then you should be thinking about Meniere's disease as your diagnosis. So in that case, there was abnormal caloric, but normal V-hit. So here I'm going to show you the progression of the recovery of the vestibular system, or central compensation, essentially. So in day one, when impulsing to the right, you can see there big overt saccades that occurred, and then A and B are on the left-hand side. We've got a mixture of covert and overt saccades. By the time day 8 had occurred, those rightward impulses, the saccades had completely gone, and the leftward impulses, you can see that they're moving earlier and earlier. The saccades are happening earlier and earlier. By day 17, those saccades have almost been removed on the left, but they've also got much smaller. So although the gain is still low, the saccades have pretty much disappeared. And then by day 31, you can see on both sides, the function is pretty much returned. The gain is still a little bit lower because there's still a vestibular impairment there, but the brain has learned to use other information to generate the VOR response, to generate the compensatory eye movement. So altogether there, we can see a picture of recovering vestibular function. It's important to look at that because some patients will describe that, yes, their symptoms have got better as they recover, but some patients will not describe an improvement in their symptoms. But it's important to discover whether their peripheral system is actually improving, or the whole system is actually improving, because in some cases that will improve, but their experience of symptoms doesn't improve. And then we're starting to think about something like pre-PD, persistent postural perceptive dizziness. So it's important then to distinguish patients that are recovering from patients that aren't recovering, and patients that have got functional recovery, but some disability that has actually stayed in place, because we need to manage those all extremely differently as a set of patients. So compensation has occurred, and then we've got full recovery that's happened at the end there. So that is V-hits in a nutshell, quite a big nutshell, but that is everything that you need to know about V-hits to get you started. So we're going to do some hands-on now, but just before we do, I just want to check if there's any questions from our online participants.
I think we'll start from the floor. Please. Yes, speaker.
Yeah. So the question was, what about the light in the room? How do you sort of set up the room for good V-hit testing? So normally in vestibular testing, we have a dark room with everything as dark as possible. V-hit, I want a nice bright room. The patient needs to be able to see the target, and the target is obviously like a little sticker or something like that. But also having a small pupil actually makes it easier for the system to track the pupil. So having the lights on and lots of light, bright room, then you'll be able to track the pupil more effectively. So yeah, open your curtains, switch on your lights for V-hit, close the curtains and switch off your light for calorics and everything else.
Any other question from the floor? No?
Yep. really good question. So the question is, what if you've got a patient who can't keep their eyes open for a very long time? Maybe they blink a lot, or because they're dizzy, they close their eyes like this very often. It absolutely happens. And you just hit your patient. No, of course you don't. You say to them, yes, this will be very fast. It won't take very long. And so, yeah, you can close your eyes, but then we'll do 10 seconds of eyes open. 1, 2, 3. We're done. You can really get it done that quickly. Or as you say, yes, do some impulses, maybe 2 or 3, take a break, they can rest. Right, get ready again, and now we go again. Yeah, but if they're blinking lots, then you have to stop. If they won't keep their eyes open, because it will just distract the system and it won't be able to analyze. And actually, sort of maybe a follow-up to that, and it's a question we often get, what about people with problems with their eyes, like damaged eyes or something like that, or they've got low vision, they can't see out of their eyes, these sorts of things. If they're blind, you can't do this testing because they can't look at the target. If they've got something wrong with one eye and not with the other, then just put the camera on the other eye, and then you can do the testing. If they've got problems with both eyes, then I'm sorry, you can't do the test. We need the eyes to actually see what's going on. Any other questions in the room? Yes. How to make a report? Yep. So the question is how to make a report in VHIT. And so what I would always do is use the IC6 report. So I would print this or add this to the patient's records and then make comments on each canal individually. So to demonstrate pathology, I would say we have low gain, so below normative data, with associated saccades, and those saccades are at least 100 degrees per second and occur at least 50% of the time. I would describe the amplitude of those saccades, so they're 100 degrees per second or 120 degrees per second, and I would describe where they occur. So were they overt or covert? So the time at which they occur as well. And that's because if you then repeat that test, those are all the things that you're going to look at. Are the saccades moving in time? And are they reducing or increasing in amplitude? And what about the gain? Is that recovering or is that staying low? And I'll do that for each canal. So for example, have we got anything on? Yeah, this is all normal. So you might have saccades that only occur in the right horizontal canal. So I'd say normal VHIT in the other 5 canals. For the horizontal right canal, we have low gain, consistent saccades that occur at 150 milliseconds. And I'd say maybe brackets, these are overt saccades. Yeah. Any other questions?
So in this case, only report the result of the gain or whatever. So we don't write down the pathology of the canal, something like that.
So me as an audiologist, I wouldn't write down the pathology. That's for my ENT colleagues to come up with, because of course that depends also on the case history, the case presentation, medication, and all these sorts of things. So yes, just the VHIT report itself, as I've described, but then yeah, for our medical colleagues then to make a diagnosis from there.
Okay, thank you. Any other question? So if not, there are 2 questions from more than 2 from the online. The first one is whether all the equipment we talk about today are available at Kasum.
Hi. So the question was, is all the equipment we've spoken about today available with Kasum? And yes, it is.
Yes. The answer is very simple. Yes, we do have all this equipment.
Yeah, exactly.
Okay, and the second question is from Just a minute. Oh, this from Dr. Andrew. This is the one who raised a question about whether there is an effect on the central lesion on pen.
Yeah.
So he asked another question. I think few questions here. The first one is, it is said that PH can differentiate between stroke and peripheral vestibular loss.
Yep.
But some studies stated that cerebral stroke can also result in decreased PH gain, and also SEC.
Yep.
So what do you think about
What do we think about that?
This is the first question.
No, good. Okay. So the question there is I think it was a cerebellar strokes can demonstrate reduction in V-hit responses. So that's a counter to the HINTS protocol that I described. So the HINTS protocol has a sensitivity and specificity in the high 90%, whereas a CT scan, for example, can have a sensitivity of around 40% in cases of stroke. So it's not to say that this will diagnose every single stroke, but as a first sort of differential test, this is going to deal with most of those cases for you. Of course, if there are other indications of stroke in the HINTS protocol, even the V-hit might not be the thing that indicates the stroke, because obviously normal V-hits occur when there's no stroke going on as well. But obviously in dizziness, then you might get an abnormal V-hit. And so the whole HINTS protocol together gives you, sensitivity and specificity of over 90% for strokes. So even if you get abnormal V-hit, but the rest of your HINTS protocol indicates stroke, then you should indicate stroke, not peripheral loss. You might have peripheral loss and stroke happening. So we need to do the whole protocol in order to manage strokes.
I think we need to depend on HINTS, right?
Exactly, yeah.
Okay, second question. Are there any tips on how doing PH in Asian patients with very small eye or elderly with very droopy eyelid?
Yeah.
So I tried to lift the eyelid with the goggles or microphore tapes, but sometimes it's very difficult. Even after I shine some light to reduce pupil size, the pupil still touches the eyelid.
Yes, that's a really good question. So the question is, and it's something we hear quite a bit, in Asian patients or in elderly patients, then V-hit can be quite tricky because the pupil, the eyelid will actually be over the pupil. And so being able to track the pupil is difficult. And doctor has suggested some of my suggestions as well, which is using either the goggle itself. So when you put the goggle on the patient, to actually pull their eye open, and then the goggle will actually hold the eye open, or to use micropore tape. So you literally tape the patient's eyes up, a bit like in the cartoons, if someone's tired, you tape their eyelid open. So that's very helpful to do as well. This particular goggle, because it's so flexible, is also better for Asian face shapes, especially with the sort of reduced bridge on the nose. There is actually we designed it for the Chinese market, but there is a slightly different shaped goggle that we sell in China that is available as well, which just the face shape is more relevant for the Chinese and Asian people. Obviously, this stuff was designed and developed in Denmark, where they're all very tall and very big, and so it's slightly difficult. Also, shining a light in the patient's eyes is a good idea, but maybe doctor might need a different goggle, and you can put that same camera on a different goggle, and it will work as well. So that might be the best solution.
Okay, thank you. So the third question from the same doctor.
Mm-hmm.
I also want to ask for tips on how to do PH on female patient with long hair.
Yeah.
What the best method to prevent goggle slippage? Yeah.
So a high ponytail. So taking the long hair, if you have the long hair down, then it's likely to slip. So putting the patient's hair into a ponytail, but putting the ponytail right at the top of the head is best. So it sort of loops like that. And then putting the goggle strap underneath the ponytail and as tight as possible. even having a hairbrush in clinic is useful, because then you can take, it's very annoying. I used to have long hair. I could have demonstrated this very well. But if you brush hair upwards like that, then you can, if you just do a ponytail high, then you get sort of like a little bulge of the hair at the back. So if you brush the hair up and put it in a tight, high ponytail, and then putting the goggles sort of strap right down, you might even need to put the strap over the patient's ears to keep it low enough. But yeah, that's the best technique I can give you.
Oh, I lost the last question. Mas, tolong, Mas.
You might find reduced. We might find reduced DOR followed. Okay, yeah. So in abnormal V hit, you will see low gain, so reduced. That's the VOR is reduced, and then the saccade is after that reduced gain. So it's sort of it's called often referred to as a catch-up saccade. So it's very fast, and it happens well after the saccade should have, or well after the eye movement should have happened.
Yeah. Okay. Okay. That's number 4 question, right? We just
we've just done that.
So there is still one more.
Okay.
If the head camera pupil detection is not exactly round because of light reflection, will that affect the VHIT result?
Yeah. So if the eye pupil isn't exactly round, then that can affect the result. So you sometimes find that if you've got lighting a bit like this in the room, then it can reflect into the lens a little bit. So if you can turn off some lights but keep some on, then that's a good idea. And then also if the sometimes you have patients with a pupil that's not circular, it has maybe a little notch in it, maybe from surgery or something like this, then I just move the camera to the other eye, which is likely to have a good pupil. It's very rare that you have 2 pupils that aren't exactly round. But again, if the patient's anatomy and physiology just stops you from being able to do VHIT, then we just can't do it in some cases. But yeah, have a look at the lighting that you've got in the room, because that can have a big effect on the reflection. The little lenses also sort of, you can bend them out a little bit and in. So if the light in the room is just a little bit odd, then you can just bend them at the front. There's sort of a little rigid wire at the front, so it can bend. So you can really get it to work as well as possible. And in fact, that's useful for some face shapes as well. Just to bend where that lens actually sits is sometimes very helpful. Okay.
Okay, that's all questions from Dr. Andrew. I really do hope answer all your questions, yeah, Dr. Andrew. I think I still have one more question from me. So I need your opinion regarding there are now a lot of, let's say, sophisticated equipment in vestibular testing, yeah, like VHIT, frame. So do you think something like caloric testing is still helpful or beneficial, because it's make patient really inconvenient with it, with that test?
Yeah, so it's a really good question. So with things like VHIT and VEMP being so easy and now available, something like caloric might seem less desirable to do. It's difficult to set up in comparison. It's uncomfortable for patients in comparison, and yeah, it can be a bit of a pain. When VHIT was first invented, some people said, caloric is dead, long live VHIT. I would slightly disagree. There's a lot that's really useful about calorics. First of all, the depth of literature that we have is really important. Secondly, you are only ever stimulating one canal at a time. Even with the perfect technique in VHIT, you will often still have some function from the other side that's occurring. There are things like the fixation index in caloric testing, which are really helpful to see if there is an overlay of central dysfunction as well as any peripheral dysfunction, and combining low frequency testing from caloric versus high frequency testing in VHIT, and then to take it even further, mid frequency testing in rotary chair as well. I would say the more developments there are, the more we understand that you need the whole picture and not just some of the picture, especially in maybe tertiary or secondary referral clinics where, you know, they may have already had some testing done, and you're really struggling with someone, you need as much information as possible. So I think we're going to have to stick with calorics for a little bit longer, even still. So yeah, don't lock them away quite yet. It's still useful, I think.
Yeah, because it's only test the horizontal canal only, right?
It is only the horizontal canal, yes, but we can learn a lot from it because we've been doing it for so long. You know, there's so much data, there's so much literature, so many useful things about caloric testing that, yeah, it's still super helpful.
Thank you.
Thank you.
So now it's time for demo and hands-on.
Fantastic. Okay. So I don't know if anyone online is going to stay with us for.
I think we already prepared with the online, bisa kan? Yeah.
Yeah.
With the video.
Yeah. Fantastic. Okay. Good. Do we take maybe a 10-minute break just while I make sure I've got everything set up and working, and then we'll start again. Brilliant. Thank you.
Saya tak ngumumin lupa. Untuk sejawat yang tadi memberikan pertanyaan, ada hadiah. Kalau yang nanya lebih dari satu, dokter Andri.
Tetap satu, Tuan.
Yang tadi mengajukan pertanyaan, ada hadiah dari Kasum GoPay.
Ya, betul.
Ada hadiah dari Kasum GoPay sebesar Rp100.000, nanti akan dikirim ke sejawat. Jadi yang offline maupun yang online yang mengajukan pertanyaan, kami sediakan hadiah GoPay 100.000. Oh, tadi yang offline Dokter Caca, Dokter Rosa, Madita sama Mas catat ya. Yang online Dokter Andrew, Dokter Bu, aku lupa.
Tadi udah dicatat sama Mas Dari.
Oh, udah. Enggak, udah. Ya, udah selesai. Ya, break untuk nyiapin. Oke. Ini ambilin aja. Makasih. Ya.
Bapak Ibu semua, kita break dulu selama 10 menit ya, sampai jam 3 pas gitu ya, 15.00 ya. Kita ambil breaknya dulu.
Bagi yang online masih bisa bagi sejawat yang online masih bisa mengikuti demo karena kita siapkan dengan video. Makasih.
Untuk praktek pijit ya dengan Mr. J. Nah, di sini ada Kang yang akan jadi pasiennya. Boleh kita perhatikan bagaimana cara mempraktekannya ya.
Okay, are we ready? Okay, great. So let's do some practicals. We've got two systems set up. So first of all, I'll demonstrate on this system, and then everybody in the room, we can also use the other system and do some practice. But I understand our colleague here is a little bit dizzy at the moment. Is that right? Yeah, okay. So we might find something. We don't know. We'll have a look. So the first thing that we said we have to do is make sure that the room is set up correctly. So we have the target here, which is roughly eye level. So not looking up or looking down so much. And then over 1.5 meters away from the target is what we need. The goggles here, actually, I think this is the Asian face shape that I mentioned. So you can see it's like just like a little wider and a little flatter than my one. So it should be more comfortable. So if you just put those on, thank you. So I'll often ask my patient just to put the goggles on themselves, first of all, just to make them feel sort of confident and comfortable about it. But then once it's on, I can make all the adjustments. So the last thing that I do is actually tighten the strap, because once it's tight, it can get a little bit uncomfortable. And although it's not going to be on the patient's head for a very long time, they can feel like, you know, I'm trying to hurt them, which I'm not trying to do. I promise I'm not trying to hurt you. And then we can see on the screen here, this is where the camera is actually showing us the eyes. So I do need to adjust the camera position so that we can see the eyes. So if you just look all the way to the left for me, all the way over to you look that way for me. Great, and then that way. Okay, you need to. And then if you look all the way up for me and all the way down, great. So throughout all of those movements, the pupil stayed in the camera, and we're not going to actually be moving the eyes as much as that, but I want to make sure that we can keep the pupil in the camera. What's also important is to have this, the bottom of the eyelid parallel with the bottom of the camera. If it's tilted off to one side, then that can just sort of affect some of the results just a little bit. But we can see here that the pupil's being tracked really nice, really, really well, very, very accurately. And even that's really useful as our colleague here is blinking, it's tracking the pupil very quickly afterwards as well. So that's great. So I'm happy with the position of the camera and everything. So now I will tighten the strap. And I do want this quite tight. I don't want to hurt our colleague, but you know, I don't want the strap too loose, because then we'll get some bad results. So. Okay, so now that's nice and tight and ready to go. We can do some calibration. So first of all, we do the eye calibration. So we can see the lights projected on the wall there. So if I start the eye calibration, so, oh yeah, oh, sorry. Okay, good. So this is middle, top, bottom, left, right. Okay, so I will say those and you will look at those with your eyes. Are you ready? So middle, right, left, middle, top, bottom, middle. Left, right, middle, bottom, top, middle. Fantastic. Very good. Good start. So we can see here that the camera is tracking it all very well, and we can see that we've got this nice cross. So I'm happy with the eye calibration there. So now I'll start the head calibration. And this is also a very useful step because I'm going to be moving my patient's head. And so it just helps me make sure that they're relaxed. Okay, it means that I'm in charge of where their head is going. So just a few like that, and then we're done with that calibration, so we can press stop. And now we can see that the camera now understands where it is in space. So we're actually ready to do our testing now. Okay. So once I press start, now the measurements have begun. And I'll just turn the sound on. It's going to tell me if I'm doing it well. So we'll start the impulses. So if you just look straight ahead for me. You can see we're getting ticks and crosses. So cross and across. So those aren't fast enough. And then nice fast impulses. And you can see I'm only moving the head very small amount. But we're still getting all the ticks. So we don't need to go really fast. Sorry, we don't need to go very far. I don't need to do all the way over here or all the way over here. I can just do quick, small. And that's technique where I'm holding the top of the head, but I can also do technique here. Okay, so we've got lots of results there. So if I press stop, then it will calculate the results for me. Okay, so we've got lots of results here now. I would ignore some of these because there's quite a lot of noise on here. But just looking straight away, we can see that the eyes are moving at the same time as the head. We haven't got that flat response on either side. Okay, there's a little bit of noise. I think I might need to tighten the strap just a little bit to go a little bit faster. But the gains are mostly really good. If we had pathological, we'd see lots of gains down here, like this. But you can see most of them are well within the normal range. At 60 milliseconds, 0.85 and 0.9. So I'm happy with those. We've got some nice normal results throughout that. Let's do route testing. Just going to tighten this up a little bit more. Okay, so now we're doing the right anterior and left posterior. So we're actually going in this direction, like this. And on the screen, it tells me as well which direction to go. So I can press start. So this time, technique's a bit different. So I'll actually put my hand on top of the head and one on my colleague's chin. So actually just moving the wire out of the way a little bit. So can you clench your jaw for me? So sort of bite down. So I ask my patient to bite so that I don't knock their teeth. So hand underneath, other hand on top. So I'm now actually pointing in this direction, 45 degrees, in the same angle as the semicircular canals. But my patient is looking directly forward. So keep looking at that dot for me. So again, very small movements, but fast movements. And I want to make sure I've got enough results so that we can average those. Well done. You can see actually there's a lot less noise now that I've tightened up the goggle a little bit. So again, we can see eye movement with respect to head movement, very good on both sides. So I'm happy with that. And then now we can go to the lark and do exactly the same, but on the other side. So this time now, right hand underneath, left hand on top, and again, straight forward and back for me as I'm pointing in this direction. If, for example, if I'm not going in the right direction, you'll see the little line here will tell me we're not going in the right direction. If I do this, see it's going straight up and down now. So that's not in the correct orientation. So it helps me to actually see that I'm going in the correct way. I must be very tired because I'm not getting any here. I'm not going fast enough. Sorry? Yeah, all three on both sides. Yeah. So 6 in total. Those would only be with beberapa. Yeah. Okay, you can take the goggles off now. So you can take them off. So now that we've done all of the canals, we've got the IC6 report. Okay, so now I can see the results from each one of those: 0.9, 0.85, 1, 0.7, 0.85, and 1.1. So looking at this, what I'd actually do is, if this was in clinic, I'd actually retest the right posterior, because we've got this 0.7, that's sort of borderline, but I can't see any big saccades or anything on here, but I'd retest those. And again, in clinic, because there's so much noise on these two traces, now that I've tightened up the goggle a bit more, I'd actually repeat those as well. But otherwise, I'm quite happy with all of the results on that. So that's how I would do it, but now it's your turn to practice, everybody. So I'd say split in half as a whole group. So half of the group on this station and half on this one. And then we'll just start testing on each other, and I'll sort of move around and keep talking to everyone. So we've had a busy day. We've covered a huge amount of different topics there, but hopefully you can see how they all sort of tie together. We've covered really looking at thinking about the vestibular end organs as a set of interconnected organs that give us lots of information about different components of the vestibular system. The challenge being that we cannot directly analyze any of those vestibular organs because they're so deeply buried in the skull. So by using our different assessment and measurement techniques, we can get an understanding of them through VHIT for the 6 semicircular canals, and then from the VEMP for the utricle and saccule. We didn't manage to practice VEMPs today, which is a shame, but we only had so much time, and you can only spend, to get some good benefit from doing practicals, I think VHIT was most useful. We even managed to find a pathology of some sort today from one of our colleagues in the room, isolated to the lateral canals on both sides, which is interesting because that doesn't point to a particular pathology individually. So it's a really good example of when we need to do some additional testing, some BNG testing, some caloric testing, trying to understand what's happened with those lateral canals, because the vertical canals were absolutely fine. Today also we thought about the dynamic visual acuity and how that relates to vestibular function and day-to-day function of a patient, and then also how it relates to developing a rehabilitation program for patients as well. And then finally, we also covered a little introduction to saccadimetry, which is the extended protocol for saccade testing as part of a standard BNG battery. So it was a broad day. Hopefully, I hope you found it an interesting day and a useful day. And I hope that there's, for those of you that see vestibular patients, I hope there's something that you'll be able to use tomorrow or next week when you see some vestibular patients. But I think the main thing to take away from the session today is that we need a mixture of different assessment techniques in order to actually pinpoint exactly where pathologies are. And then when we do pinpoint exactly where pathologies are, we can design correct treatment and correct rehabilitation for those patients. So thank you very much, everybody. Thank you so much.
Okay, finally, we come to the end of this seminar today, and on behalf of Kasum Hearing Center and all of the participants online and offline, everybody complained that they can hear my voice. I feel that is not enough yet. So we would like to thank and grateful to Jack Bennet to share your experience in dealing with vestibular diagnostic testing. So with the hope that it will be beneficial for all of us, and also for those who raised questions. One colleague from Malang actually raised about 6 questions today. And I know he is the one who really interested in, we call it here neurotology. And thank you for all the, for all the participation online and offline in this seminar. So we do hope that we can meet in another seminar.
I look forward to it. Yeah, I hope so.
Oke, terima kasih. Mudah-mudahan manfaat untuk juga teman-teman sejawat yang ikut online. Mudah-mudahan bisa manfaat. Mohon maaf untuk FEM, barangkali dilanjutkan besok pagi, because they have to leave to Bandung. So 3 of us is to Bandung for tomorrow's workshop. So maybe FEM, we hope that we can show the demo tomorrow. And Dr. Madita still around tomorrow. Okay, again, thank you. We do hope that you enjoy the rest of your stay in Jakarta. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam, terima kasih.
Alhamdulillah, puji syukur kehadiran. Ya. Ya. Baik Bapak dan Ibu rekan-rekan dokter sekalian yang mengikuti acara seminar ini secara online, acara ini kami tutup dengan mengucapkan alhamdulillah. Mohon maaf atas segala kekurangan selama pelaksanaan acara ini. Saya mewakili panitia mohon undur diri. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.